Today, we're going to be starting with question 126 and going all the way to 200. So, get a bag of popcorn and get your study notes, first aid, and let's just dive right in. So, our first question, we have a 35-year-old woman presents to the dermatology clinic with concerns about her skin. She has multiple small, scaly patches on her upper back and shoulders over the past few months. The lesions have not been itchy, but she is worried that they have become more noticeable after sun exposure. She has no other significant medical history and takes no other medications. A wood lamp examination reveals yellow-green fluorescence in the affected areas. Which of the following is most likely the causative organism? Okay, we got a couple of options here. So there are a couple of things to note. First of all, it's not itchy and it's well demarcated and it's scaly. And not itchy, scaly should make us think of maybe a fungus infection. And the yellow-green stuff on the wood lamp, that's just a diagnostic clue, but this is malassezia furfur, and this is going to be tinea versicolor. All right, now here's the explanation. Tinea versicolor, caused by malassezia, a lipophilic yeast. Manifests as hypo and hyperpigmented scaly macules, commonly found on the back and the chest after sun exposure. Trichophyton rubrum is associated with dermatophytes that causes tinea corporis or pedis, athlete's foot. That would cause a pruritic, itchy, ring-shaped lesion. Aspergillus would have a fungal ball, but this is not a skin pathogen. Microsporum, involved with tinea capita, and histo would be in this region, Ohio River, with bird and bat droppings, and also pulmonary symptoms. Now, this is caused by malassezia furfur, which is a normal part of the skin flora. It's pathogenic in hot and humid environments or when the patient is on immunosuppression. The organism damages melanocytes and inhibits tyrosinase. So the pathophysiology is that it's normally in the stratum corneum, and then it's triggered by heat and humidity. And then all of a sudden, we get this acid production that inhibits melanin synthesis, and you get the pale or variably pigmented macules on the front or the back. They're the features. So basically, it's yeast on your skin that glows under UV light as well, and it's non-itchy, scaly pigments on the back that is more obvious after sun exposure. So these tineias, the dermatophytes, they're mold infections that can eat keratin, ring-shaped and itchy, and tinea versicolor is malassezia yeast overgrowth. So you have color change, not infection, and it's not itchy, is malassezia. That's how to distinguish between them. So here's the bottom line. Yellow-green fluorescence under wood lamp indicates malassezia furfur as the causative organism of tinea versicolor. And you have to know how to distinguish tinea from other types of tinea. Versicolor is non-itchy, different pigmentation, non-infectious, and caused by malassezia. And our next question is, 70-year-old man is being evaluated for worsening low back pain and generalized weakness. His medical history shows that he's been treated for CLL. Over the past 5 years, recent lab shows elevated serum calcium level. As part of the management, he has started on glucocorticoid therapy, which alleviates some of his symptoms. Glucocorticoids exert their effects primarily through a receptor that binds to which of the following locations? Glucocorticoids. That's a nice, easy way of framing this. There are different ways that we could kind of have made this question much harder, which I'll get at soon. But glucocorticoids, these are going to be going straight into the cytoplasm because they are steroid hormones. They act as intracellular receptors, not cell surface ones. So it's not A, and they're typically going to be in the cytoplasm. So it literally diffuses across the plasma membrane due to their lipophilic nature. And then they bind to these receptors, and then they get translocated into the nucleus. The cell surface, that would be like peptide hormones. For instance, insulin, which uses membrane-bound receptors. Glucocorticoids are lipophilic. They go straight through that membrane. Mitochondria is involved with apoptosis regulation, and it can influence the mitochondria, but it's not the primary receptor for glucocorticoids. The Golgi is for post-translational modification and involved in protein trafficking. And then RUF is involved in protein synthesis. So here are some associations. Steroid hormones, think cortisol, aldosterone, testosterone, all the ONs, estrogen, and cytoplasmic or nuclear receptors. Also for steroid hormones, you can think of tamoxifen because it's lipid soluble and it can cross the membrane freely and it'll just go straight to the nucleus. So tamoxifen is kind of another intracellular receptor agent. So here are the key features. Lipophilic hormones cross the membrane. They bind to the intracellular receptors. Glucocorticoids decrease inflammation, and you get lower immune response and less vitamin D-mediated calcium absorption. Sadal says, another good day to lock in and study. Amen to that. What a beautiful day for that. Cytosol, also known as intracellular fluid, is the liquid component of cells. It contains water, dissolved substances. Clinical outcome, disturbances in cytosol lead to cell dysfunction, and it'll respond to you in the chat. So that's a new feature for everybody on Twitch. Right now, it's just free for everybody to use. Oh no, it's already being used for different purposes. How can I get more tomatoes in Blake's stream? Your question seems unrelated to Step 1 content. That's funny. Yeah, I guess it's only good for Step 1 content, but let's dive into our next question, shall we? A 35-year-old man presents to the clinic with fatigue, unintentional weight loss, and recurrent fevers over the past 2 months. He has a history of untreated HIV infection. Physical exam reveals generalized lymphadenopathy and oral thrush. Lab testing shows a CD4 count of 150 and viral load exceeding 100,000 copies. In addition to CD4 positive T lymphocytes, it is most likely to serve as a reservoir and site of HIV replication in this patient. Okay, yeah, we'll deal with that question as soon as we finish this one. So macrophages is correct. Very nice. HIV targets the T cells and also in the macrophages. They're both reservoirs and replication sites for HIV. So HIV primarily affects the CD4 T lymphocytes, but also can affect the macrophages. Epithelials are barrier cells. They don't have that CD4 and CCR5 expression. B lymphocytes, antibody-producing cells, there's no major reservoir there. Red blood cells do not have a nucleus, and so the red blood cells can't harbor or replicate the virus. And eosinophils, parasites, and allergic responses are not involved. Less than 200 is going to risk the opportunistic infections. Acid fast, like mycobacterium, is seen in HIV when macrophage immunity is impaired. Acid fast. And our receptors here are the co-receptors on the macrophages and the T cells, which are needed for HIV entry. So CNS, HIV infects the microglia, leading to HIV-associated dementia. That's how HIV can cause dementia in your brain through microglia. Pulmonary disease, the alveolar macrophages can be sites of it. Here's the pathophysiology. Here are the key features. And here is the bottom line, my friends. So macrophages serve as the key reservoir for HIV replication in patients with advanced immunosuppression. Okay, now let's check out hematopoiesis's question. Because hematopoiesis gave a question to my bot, and they said that they got it incorrect. So let's see. We have a 25-year-old presenting with palpitations, sweaty palms, and tremors. They have past medical history of thyroid cancer. Serum calcitonin is notably elevated on the labs. What is the diagnosis? Medullary thyroid carcinoma as a part of MEN2A, MEN2B, because of the concurrent catecholaminergic symptoms. Medullary thyroid carcinoma as part of MEN2A and 2B because of the concurrent catecholamine symptoms. Nice. Very cool stuff, guys. Very cool. It's partially right. We give GPT a partial correct. I like that. That was a good question to test how far it can go. Okay, guys, here's our next question. A 25-year-old graduate is working on a research project involving genetic mutations and their effects on protein synthesis. During an experiment, the student observes that a mutation has changed the third nucleotide of a codon. Oh, but the resulting is the same as the wild type. This observation prompts discussion about the supervising professor regarding the nature of the genetic code, which explains this finding. So we have a synonymous or a silent mutation that is occurring at the third base of a codon, and this is probably due to some sort of a redundancy, as hematopoiesis said. Very nice. A redundancy in the genetic code because multiple codons are encoding for the same exact amino acid. This genetic code is redundant. And that's the correct answer. It's C. And it is indeed redundant. Most of the amino acids are encoded by more than one codon. And so this redundancy is especially prominent at the third nucleotide position. This is known as the wobble position. Wobble, baby, wobble, baby, wobble, baby. Right? Yep. Very, very relevant. I love all the salutations in the chat. That's so fun. Universal, shared across species. That's not relevant here. It's that wobble protein, the redundancy. Yep. Built-in backup mechanisms to prevent against small mistakes. Here's the bottom line. The redundancy of the genetic code allows for mutations without altering the resultant amino acid sequence. Yes, David, I'm talking about you. You're pregnant. Hopefully you guys know type 1, type 2 errors, because that's what this next question is going to hit on. Here we go. And I've drawn this out because I think it's a fun way of remembering type 1 errors is if you call a man pregnant. And so type 2 errors are if you call a woman who clearly is pregnant, not pregnant. Yeah, hypothesis testing. So in a clinical trial, we are comparing two medications for lowering blood pressure. We determine we need a sample size that will give them 85% power to detect a 10 milligram mercury difference in systolic pressure, with two-sided significance level set at 0.05. Assuming there's truly no difference between the medications, what's the probability that they will conclude a difference does exist? Well, that's it. Basically, there is no difference. There is no pregnancy, but you're saying that they are pregnant. And so this is a type 1 error. So we know our type 1s are going to be the correct answers. And then it's going to be a 5%. A 0 would not make any sense at all. A 5% significance level says there's a 5% chance of falsely concluding that a difference does exist. When no true difference exists, only one kind of error can be made, type 1. The alpha, type 1 error, we say that there is a difference when there isn't one. And the beta, type B, is a false negative. We say there's no difference when there is. And then the power is 1 minus beta. The ability to detect a true difference when it does exist is the power. Yeah, David W. We call him David W. With no true difference, the study has a 5% chance of a type 1 error concluding significance. David is pregnant, everybody. That's what we've learned. What are you going to name the baby, David? Blake Jr.? All right. In our next question, a 60-year-old man presents to the emergency department with shortness of breath and persistent diarrhea. His symptoms have been progressively worsened over the past 6 months. He also reports several facial flushing episodes and has recently been diagnosed with new-onset heart failure, affecting the right side of his heart. His past medical history is significant for hypertension managed with lisinopril. On examination, he's found to have hepatomegaly, and cardiac auscultation reveals a loud systolic murmur over the right sternal border. Which of the following is the most likely primary location of the underlying mechanism? We're thinking carcinoid. We have some flushing. See that? Flushing. Why do we highlight flushing? And the right-sided valvular disease. What is this? We got some fibrosis, probably. Some serotonin-induced fibrosis in the small intestine, we're thinking. Man, Sedal is unstoppable. We got to find one question that can stump him. Indeed, this is correct. This is carcinoid syndrome. Via Sedal, indeed. So they have carcinoid syndrome, a paraneoplastic syndrome caused by a neuroendocrine tumor that secretes serotonin and other vasoactive substances. We get diarrhea, flushing, bronchospasms, right-sided heart failure, especially tricuspid regurgitation. Appendix for asymptomatic carcinoid. Lungs would involve bronchial carcinoid and be without liver metastasis. The pancreas has lipoma, insulinoma, gastrinoma, and the stomach type 1 and 3 gastricarcinoids. Hematopoiesis, diarrhea is going to be persistent and watery in carcinoid syndrome. And also you have a shortness of breath and right-sided heart failure. So there's fluid buildup that causes a loud murmur and hepatomegaly. So these are going to be a classic triad of the carcinoid syndrome: flushing, diarrhea, shortness of breath. And so that's carcinoid. And what causes carcinoid? Well, carcinoid syndrome happens when a carcinoid tumor is a neuroendocrine tumor and it makes way too much serotonin. Way too much serotonin, 5-HT, right? And other signaling molecules like bradykinin and also histamine. Histamine is going to be present there too, and bradykinin. And that causes the flushing, the vasodilation. The diarrhea is the increased motility, and the fibrosis of the heart valves, especially the right-sided fibrosis, causes heart failure and a murmur, which was in this patient. And so why right-sided as opposed to left? Do you guys know? So serotonin is going to damage the try before you buy, and the pulmonary valves, not the left side, because serotonin is inactivated by the lungs. That's the lungs inactivate serotonin. And so it's like it purges it so the left side is not going to experience those serotonin side effects. So serotonin reaches the lungs, boom, it gets neutralized, and the left heart never sees it, right? And so even if somebody has carcinoid tumor in their gut, the symptoms don't appear until the tumor spreads and metastasizes to the liver. And the reason why is if you have a tumor in your normal small intestine, then the serotonin will go to the liver first through the portal circulation, and then the liver destroys it and you have no symptoms. But after you have metastasis to the liver itself, then the tumor is inside of the liver. And so it'll bypass liver metabolism and you get systemic symptoms. Okay, David, that's an interesting question. Isn't serotonin a love hormone? How do the lungs flush it out? That is a really, really good question, but it's actually not. It's oxytocin. It's probably what you're thinking about, right? Oxytocin is going to be like the whole bonding, social attachment hormone, and also childbirth and trust. Like literally, you can't give birth without oxytocin, the love hormone, right? So serotonin, on the other hand, is a neurotransmitter that's involved in mood regulation. So typically, you give somebody an SSRI, that's serotonin. Depression, you give them fluoxetine, that is a serotonin reuptake inhibitor. So it's involved in mood regulation, sleep, appetite, other bodily functions, right? So serotonin is involved in that is involved in that stuff. But romantic love, serotonin actually does play a little bit of a role in the romance, right? But it's not the being in love, right? The studies actually show that in an early stage of romantic love, serotonin levels can actually decrease, interestingly enough. I don't know why, but yeah, so serotonin is not the love hormone. You're probably thinking of oxytocin. But then you asked another question. You asked, how do the lungs flush out serotonin? Well, in carcinoid heart disease, right, from the mid-gut neuroendocrine tumor that produces a whole bunch of serotonin, the lungs and the liver metabolize the serotonin before it can actually reach that side of the heart. And so the mechanism is basically the lungs metabolically inactivate the serotonin as the blood passes through the pulmonary circulation, and that stops the 5-HT from ever reaching the left side of the heart. So it metabolizes 5-HT into the inactive metabolite. Wait, Sedal, you activated push-ups? All right, push-up time. Here we go. All right. Thanks for the push-ups. That was nice. That was great. No, David was inactive. Nothing like logging onto Twitch and watching people do push-ups. All right. Let's do our next question. If I'm a little bit out of breath, it's because one of our viewers just made me do 20 push-ups. So a 47-year-old worker presents to the clinic with complaints of numbness and tickling in her right hand that began a few weeks ago. She states the symptoms are worse at night and after using the computer for extended period. On physical examination, there's mild atrophy of the thenar eminence on the right side. The patient has weakness with thumb opposition and positive sign at the wrist. Sensory examination reveals decreased sensation to light touch on a specific area of the hand. Which area is most likely affected in the patient? Okay, so you got thenar atrophy and also nighttime worsening. That's carpal tunnel syndrome, if that helps. Yep, you got it, Sedal. So carpal tunnel results from the compression of the median nerve within the carpal tunnel of the wrist. And so you get weakness in the thenar eminence. And the answer that David said is true. Palmar surface on the thumb, index, and the middle fingers. So they have classic carpal tunnel, compression of the median nerve, hallmark, involves the palmar surface of the lateral 3.5 digits, the thumb, the index, and also the middle, lateral half of the ring. And the motor symptoms are a weakness of the thenar muscles, especially thumb opposition. The pathophysiology is you have repetitive wrist motion, you increase pressure on the carpal tunnel, compression of the median nerve. You get sensory loss in the palmar, thumb, and the radial half of the fingers. David says, me after playing Minecraft for 8 hours. Yes, indeed. No wonder all you millennials have carpal tunnel. Here's the bottom line. Carpal tunnel syndrome affects the palmar surface of the thumb, index, and middle fingers due to median nerve compression. All right, in this one, we have a 78-year-old man presenting to the primary care physician with concerns about spots on his forearms. He has noticed several red and purple blotches developing on the dorsal surfaces of his forearms over the last several months. Upon examination, large non-blanching purpuric patches are observed on both forearms, with no signs of trauma or laceration. His medical history is notable for well-controlled hypertension, and he takes lisinopril daily. He denies any platelet-taking or anticoagulant medications. Lab tests, including complete blood counts and coagulated profile, are within normal limits. Which of the following is most likely the cause of his skin findings? So he's got some old skin. So aging and chronic sun exposure can lead to dermal collagen and elastin atrophy. And that causes the fragile blood vessels to rupture, and you get large, flat, non-blanching purpura on the dorsal forearms with normal lab tests. So this is just senile purpura. Vitamin C deficiency would cause perifollicular hemorrhaging, gum bleeding, and poor wound healing. So that's not it. Von Willebrand causes mucosal bleeding like nosebleeds, menorrhagia, and prolonged bleeding time. ITP, that would show low platelet count on the CBC with petechia and also mucosal bleeding, not just the forearm bruising. So ITP has to have thrombocytopenia. It's in its name. Low platelet counts and also petechia and mucosal bleeding as well. HSP is going to be more commonly in children. Presents with palpebral purpura, arthralgias, abdominal pain, renal involvement. Not seen in the elderly though. So younger kid, cytopenia, thrombocytopenia is going to be seen there. No bleeding issues, different presentation. So it's senile. Here's the bottom line. Senile is common in elderly patients presenting as non-blanching purpura without trauma. All right, on to our next question. So here, a 29-year-old man is undergoing evaluation for hypertension. Imaging reveals unilaterally absent left kidney. Further investigation does not indicate prior surgical removal. Why is his left kidney not developed? Renal agenesis. Well, the answer to this one is renal agenesis happens when the uteric bud stops inducing the metanephric mesenchyme. So it's the metanephric mesenchyme that's the embryologic origin of the kidney's nephron structures. So it's unilateral renal agenesis. And so the answer is A, failure of the uteric bud to invade the metanephric mesenchyme. And because this is not due to surgery, it must be embryologic, and there's something wrong in the kidney development. And normally, there are 3 stages of kidney development. There's the pronephros, that's early, right? And then it degenerates. There's the mesonephros, that is temporarily the kidney for the first trimester, the mesonephros. And then it becomes part of the male reproductive duct. Then it becomes part of the male reproductive duct via the mesonephric, the Wolffian duct. And then you have the metanephros. And that is the permanent kidney that forms starting week 5. And there are 2 simultaneous structures that need to be in order for this to happen. So one is the uteric bud, and that's also called the metanephric diverticulum. It's an outgrowth from the mesonephric or the Wolffian duct, and it forms a lot of things. The ureter, renal pelvis, the calyces, the collecting ducts. And the metanephric mesenchyme, that gives rise to like the glomeruli, the proximal tubule, the loop of Henle, the distal convoluted tubule. And the uteric bud has to go invade the metanephric mesenchyme to induce nephron formation. If that fails, then the nephritic tissue can't differentiate, and so no kidney is going to form. Okay. There we go. So unilateral is caused by that failure there, but then bilaterally, you could have like oligohydramnios and Potter sequence, things like that. And then unilateral renal agenesis is usually asymptomatic and involves other kidney hypertrophies. Congenital absence of a kidney is typically due to failure of the uteric bud to invade the metanephric mesenchyme. All right, here we go. A 26-year-old professional soccer player presents to the sports medicine clinic with swelling on his right knee following an injury at the game. He reports that he was running when he suddenly decelerated and twisted his knee awkwardly. On the physical exam, there is significant joint effusion and tenderness along the joint line. Lockman's test is negative, but the posterior drawer test is positive. What does that mean? All right, so MRI of the knee is obtained, and we have to know which structure is going to be injured. I wanted to draw out some of these structures and have that be the kneecap, but alas. So the drawer sign, what does that tell us? The positive posterior drawer sign. Positive posterior, that tells us that it's posterior cruciate ligament tear. And so it's sudden deceleration, David. So the answer is B, posterior. So the posterior drawer test is positive, so it's the posterior cruciate ligament. So this is diagnostic for a PCL injury. It prevents posterior displacement of the tibia relative to the femur. So they're decelerating and then twisting, and that's a very common kind of cause of this. And the posterior drawer, the Lockman's test is going to be negative. That means that the ACL is intact. And the posterior drawer is positive, so it's a PCL injury. Yes, Lockman would be the ACL injury, and the posterior jaw is the PCL. And usually that can be caused by several things. You have to know USMLE loves asking everything about pregnancy, which physiological changes are going to be seen. So here I'm just going to write this one out. So let's say that we have a 30-year-old woman. David's water is breaking. Yep, it's a 30-year-old woman. She's 32 weeks pregnant, so she's in her third trimester. And let's say she feels well. She has virtually no problems, and she has normocytic anemia. So her MCV count is at 85, and her hemoglobin has dropped from 12 to 10.8 over 8 weeks. All right, so is this pathology? Is this pathological anemia? What happens here? Well, what's happening is that the plasma volume is going to change during pregnancy. Plasma volume increases by like 40 to 50%, and that will dilute the blood. And then you have red blood cell mass is also going to be increasing by about 20 to 30%. And that helps with the oxygen supply to the fetus. And so the net effect is you have a plasma increase, and the plasma increase is usually greater than the red blood cell increase. And so that causes hemodilution, which is physiologic anemia of pregnancy, which is exactly what this patient's undergoing. Physiologic anemia of pregnancy. Yep, Dr. Kawasami got it. Dilutional anemia. Nice. Hey, music playlist. Hey, tomorrow's my step 1 exam. My scores on MBMEs have been low, and I have only passed free 120. What should I do one day before the exam? I'm going to send you an article. The big thing that I would say, though, is pretend that it's test day. Try to get to bed as early as you can while feeling normal. Get a good night's sleep, right? And also get a good breakfast as well today. Just try to mimic testing conditions as much as you possibly can today, and then take it easy on your brain. Maybe some light review. I would say just don't really study much at all. Maybe just memorize all like the low hanging fruits. Like if you want to just hang out on the stream and just have a good time, eat some food, have a good time, like just chill. Just stick to your normal diet though. Yes, good luck indeed. Good luck. Yep. Organize your documents, right? Get everything ready that you need. Eat, hydrate, try to relax, sleep. Yep, just get your mind and your body ready, right? Take the day off of studying and really just get yourself prepared mentally. If you want to just hang out in the live stream, that's cool too. Just whatever makes you feel just chill. Okay, here we go. Next question, and very good luck. You're going to kill it. 42-year-old man visits the neurologist due to persistent muscle stiffness and cramps in his lower limbs for the past 8 months. He has occasional tremors and involuntary muscle spasms, which have made it difficult for him to perform daily activities such as walking or standing for extended periods of time. I'm glad the MBME reviews have been helpful, man. Thanks. A therapeutic intervention that targets which of the following mechanisms is most likely to alleviate the patient's muscle spasticity. Okay, so we're alleviating the spasticity, so we need some sort of an inhibitory mechanism. And so spasticity is caused by the loss of the descending inhibitory input. That's why you're spazzing up, your loss of the inhibitory. And what are the key inputs there is glycine and GABA. They're the key neuro inhibitors of the spinal cord. And so it's going to be the glycine receptor mediated chloride ion influx in the spinal internal neurons. So they have muscle stiffness and also cramps, and they have involuntary spasms and increased tone. So they have like spasticity, and they have hyperreflexia and a positive Babinski sign bilateral. So all of that tells us that they have an upper motor neuron lesion. And so that's seen in a lot of disorders like multiple sclerosis, spinal cord injury, stroke, and also like ALS, right? These are all upper motor neuron kind of diseases. So MS, spinal cord, stroke, ALS. And the question is like, what mechanism would reduce the spasticity? And so spasticity occurs because of the loss of inhibition. And so normally the inhibitory interneurons in the spinal cord, especially the Renshaw cells, are going to release glycine and GABA. Go GABA, GABA. And the upper motor neuron is damaged. And so you have inhibition is decreased, and alpha motor neurons are going to become hyperactive. Alpha motors are hyperactive. And so you have spasticity, hyperreflexia, and clonus. And so there are a lot of drugs that actually reduce spasticity. One of them is baclofen, right? The mechanism is GABA B. And the target for baclofen is going to be the spinal cord. And the net effect is you have increased potassium outflow, which hyperpolarizes and causes decreasing of the motor neuron firing. So there are some drugs that do this, and they usually interact with GABA. So GABA glycine is what you should be thinking of. Like diazepam, for instance, that's GABA A receptor agonist, and that's for the spinal cord of the brain. And that causes a chloride influx. Dantrolene blocks calcium, and that's decreasing the contractor strength. And glycine agonists. Those glycine agonists increase the chloride influx in the glycine receptor, and that causes a decrease in the alpha motor neuron firing. And so here we're doing glycine receptor mediated chloride influx in the spinal interneurons. That's our correct answer. All right. So spasticity, buzzwords. You have the increased tone. You have velocity dependent resistance, Babinski signs, hyperreflexia. Give them some baclofen, GABA B, act similar to glycine, and glycine through the chloride channels. It'll open those chloride channels, right? You want to hyperpolarize the motor neurons. So that'll reduce the spasticity. Here's the bottom line. Targeting glycine receptor-mediated chloride influx alleviates muscle spasticity in conditions like upper motor neuron lesions. 12 more questions until our break. All right, in this question, we have a 25-year-old male who's brought to the emergency department, collapsing while jogging. They're unconscious and complains of weakness and shortness of breath. Vital signs show a heart rate of 78, blood pressure of 92 over 60, oxygen sat at 97% on room air. Cardiac auscultation reveals a faint S1 and S2 with no murmurs. Jugular venous distension is noted. Lung examination is clear. Echocardiogram shows a normal-sized heart with ejection fraction of 30%. Lab shows normal electrolytes and negative troponin. Based on these findings, which the following mechanism is most likely responsible for his symptoms? So this ejection fraction is low. He has a normal-sized heart, and he has low blood pressure as well. Low blood pressure. So there's like some sort of a pump dysfunction. It's not a volume problem, it's a pump problem. So what do you guys think? Hypotension. Let's say there's also elevated central venous pressure, right? Because of that jugular venous distension. His lungs are clear, right? So that's not left-sided or fluid overload. Because if it's fluid overload, then it's going to back up into the lungs. So he's severely reduced contractile function because of that ejection fraction. And so the answer is going to be decreased cardiac contractility. Here's the brief explanation. Here's what he's got. Hallmarks of systolic failure. He's got decreased contractility. It's not, if you're on the left side, you'd have pulmonary symptoms. Decreased afterload, that would help the failing ventricles. Nice. Increased preload, more filling, that would help with the cardiac output. But the JVD is a result of poor forward flow. There's a nice equation right there. In young people, think viral myocarditis, inherited cardiomyopathy, or toxin-induced injury through alcohol and drugs. If it's less than 40, think systolic dysfunction. Here's the bottom line. Patient's symptoms indicate decreased cardiac contractility due to low ejection fraction despite normal heart size. Normal heart size, decreased fraction. Okay, on to our next question. Oh, there's a question in the chat from Dr. Kawasami. Wanted to ask about GABA B and GABA A in terms of their function and uses. Yeah, let's add that to the community questions pile here, and let's hit that. GABA A and GABA B. We can do that now. Okay, so answering a question in the chat, GABA A and GABA B in terms of function and uses. So let's do a quick overview on this. So GABA, which is gamma-aminobutyric acid, that is the main inhibitory of the central nervous system. And so this is going to decrease the neuronal excitability by hyperpolarizing the postsynaptic membrane. It hyperpolarizes, and it acts through two receptor subtypes, which is what this question is about. The first one is the A one, and that's ionotropic. And so that's throughout all of the CNS, especially the cortex, the cerebellum. Yep, it's ionotropic. GABA A is ionotropic. And the ion signaling mechanism is ligand-gated. It's a ligand-gated chloride channel, and that causes, ligand-gated ionotropic. That is GABA A. Now, GABA B, this is not going to be as everywhere as A. This is involved in the spinal cord and also the brainstem. And this has a different mechanism as well. This is a G protein coupled reaction. GABA B is. And so that opens up the potassium channels and it inhibits the calcium channels. Opens up the potassium and it inhibits the calcium channels. Okay, so the GABA A, this is like very fast inhibition. This is right. So GABA binds and then it causes the chloride to just flow in, and then the membrane becomes hyperpolarized and now the neuron just can't fire. That's why it's inhibitory. And this is like milliseconds. This is like super, super quick. And there are a ton of drugs that act here. Benzodiazepines are the most high yield. So diazepam, lorazepam. The mechanism is increasing the frequency of the chloride channels. And that's used for like anxiety, for seizures, for muscle relaxation, and also insomnia. Barbiturates also, like phenobarbital, that increases the duration, barbiturations, right? And that's increasing the duration of the chloride, but it's still chloride, you know what I mean? It's still hyperpolarizing inhibition. And that is used for like seizures, anesthesia induction. Also alcohol, right? Alcohol potentiates GABA A, and that's used for, sedation. Especially in the olden days, they used to give alcohol for that. And then also the Z drugs, those are also used for insomnia. And then the anesthetics like propranolol or propofol, and that enhances GABA as well. That's used for sedation. So you can use this for sedation pretty well. And GABA B, that's slower inhibition. So GABA B is slower inhibition, and that is a G protein coupled receptor. And so that activates the potassium efflux and the calcium influx. And so you get hyperpolarization and decreased neurotransmitter release. And that's slower. That's like 100 times slower. But it's still like milliseconds or maybe like a second. And this is mainly in the spinal cord. And the drugs there is like baclofen. So baclofen, GABA B for baclofen. Yeah, you're right. GABA B for baclofen. And so that's used for muscle spasticity and spinal cord injury or multiple sclerosis. And then baclofen's like the most high yield because baclofen for back, B for back, right? Spinal muscle relaxation, B for the back. And that's pretty much all there is to it. You know, B is slower, has potassium efflux, There's calcium influx, and it's slower, baclofen, GHB, spasticity. So really the time course is one of the biggest differences, but also the physiologic kind of mechanism at play. And then you said the previous question was about GABA A. Yeah, the previous mechanism was about glycine receptors, right? Glycine receptors and chloride influx. And that is functionally analogous to GABA A, not GABA B, because they both cause, rapid neuronal inhibition through the chloride entry. But glycine acts mainly on the spinal cord, while GABA A acts throughout the brain. All right, so hopefully that clears things up. Great question. Thanks for asking it. Now let's dive into this one. So here we have a 47-year-old woman presenting to her primary care physician with a complaint of tingling and burning sensations on both of her hands that began 6 months ago. Thank you, Dr. Kawasami. I love your questions. They're always really insightful. Okay, so she's got the tingling. Her spider senses are going off. Sensations on both of her hands that began 6 months ago. She has a history of poorly controlled hypertension and hyperlipidemia. Her occupation involves constant typing. Relatable. But she denies any acute injury to her hands. She's like, nah. Physical examination shows normal strength and reflexes with decreased sensation to light touch and pinprick, which the following mechanism explains her symptoms. Okay, what is explaining her symptoms? Hypertension, hyperlipidemia, a glove-like distribution of both hands, diabetic neuropathy. Okay, so the correct answer is D. Persistent activation of voltage-gated sodium channels and peripheral nociceptive pathways. Okay, she's got the glove-like burning. That's diabetic peripheral neuropathy, just as Dr. Kawasami said, 100%. This is chronic hyperglycemia leads to axonal damage in the unmyelinated C fibers, the stocking glove. This pain is mediated by the persistence of these sodium channels and producing spontaneous depolarizations and neuropathic pain. The large fibers remain relatively spared, and that explains the preserved strength and reflexes. Okay, so decreased expression of voltage-gated calcium, that's Lambert-Eaton syndrome. Proximal muscle weakness, that's improved with activity. Increased density of L-type. L-type is linked to smooth muscle contraction and cardiac function. Increased synaptic release of GABA in the CNS, that would cause sedation, as we've talked about before, or inhibition, right? It reduces, these are inhibitors, and I think we've made that really, really clear. The keyboard got stuff, gotcha. Reduced conduction velocity in a delta fiber due to demyelination. That's Guillain-Barré. Sufjan Stevens had Guillain-Barré. I always like to remember that. One of my favorite artists of all time. A chronic demyelinating neuropathy, which causes weakness and are not length-dependent sensory neuropathies. So peripheral neuropathies and diabetes are length-dependent. The longest are damaged first. That's why it's the stocking glove, which should key you into this. And then you just have to know the mechanism is going to be with that sodium and the nociceptor pathway, hyperexcitability of the sodium, which causes that pain. All right, so there's the pathophysiology of hyperglycemia. Glucose is converted to sorbitol in the Schwann cells, the peripheral nervous system. You don't want the sorbitol in the peripheral nervous system, right? So that causes the stress and the oxidative injury. And now you have microangiopathy and you have endoneurial ischemia, which causes axonal degeneration. And you have the loss of the unmyelinated C fibers, and that causes the burning. There's also that persistent sodium channel activation. All right, so half of diabetic patients are going to develop some form from the sugar alone. You still answered so quickly. So chronic hyperglycemia batters peripheral nerves, especially the long ones in your feet, in your hands. So glucose builds up in those Schwann cells, converts it to sorbitol, drains the water, stresses and damages the cell. That's what's going on, folks. Here we go. Bottom line, glove-like sensory loss in the hand suggests peripheral neuropathy, likely due to reduced conduction velocity for demyelination. Yep, we're on to our next question, 140. Hey there, study partner. How you doing? There's always a little break before the next question just because it's got to load. But if you have any questions in the meantime, happy to answer them. And then typically I like to go to this page right here, take some notes on the next question to kind of gather my thoughts. But yes, we're doing the next question. We have 10 more. 10 more to go. And then we're taking a break, and then we're going to do 50 more. Also, good to see you. I think that's the first time I've seen in the chats. Welcome. Awesome. And then Dr. Kawasami has a question. Let me go over here to the community poll, and I'll write that down. And I'll be releasing this document to you guys afterwards as well. So I'm going to copy your question here. Copy. And I'm going to do text. Oops. Text. Paste. Oh, no. Let's try that again. Paste. Yeah, that's good enough. Tell us about micro versus macro angiopathy complications as quick as you can. Okay. I just realized. Okay. Sounds good. So you're asking about some complications of diabetes then and the small vessels. So basically what I would say is like the micro vessels versus the macro. So the micro, you have the small vessels, right? And so that's going to be like the retina, the kidney, nerves, right? The brain, and also the limbs. So that's like for very, very quickly, like that's what's most high yield. You're asking about the diabetic complications, right? From chronic hyperglycemia. And basically all these problems are caused by non-enzymatic glycosylation and then sorbitol accumulation, right? And so there are different types. There's microangiopathic, and there's also, right? So microangiopathic, which is this one right here, microangiopathic, that's non-enzymatic glycosylation of the vessels, so capillaries, arterioles, and the basement membrane thickening, and that causes like the leaky stuff, and it's really ischemic, that kind of stuff. The targets are really the main difference there. For micro, it's the retina, the kidney, and the nerve. And so some examples of that are like retinopathies, microaneurysms, hemorrhages, neovascularizations, and then also neuropathies, like basement membrane thickening, expansion, the chemostem Wilson nodules. All of that stuff is associated with micro, the retina, the kidney, the nerve. And the neuropathy is caused by ischemia plus sorbitol accumulation, and you get the glove stocking pattern. That's micro, right? And then your other question is about the macro, right? And that's the coronary, the cerebral, the peripheral, the limbs, right? And myocardial infarction is most common. And then the stroke, you could have like a stroke, you have like peripheral vascular disease. And a big thing to think about for like macro is like gangrene is one that comes to mind with macro. Other than that, I don't really know what else I would say. I guess just you have accelerated atherosclerosis in their large vessels, and that's due to like the macroendothelial injury and also like the LDL glycation. So hopefully that makes sense. Okay, you're preparing for the AIMS exam. You wanted to solve a few? 100%. Yeah, we'll be here all day, man. If you want to just like mute the stream and then hang out, and then you can just join in whenever we have them. That way it's like super efficient for you. Whatever works best for you, We're here for you. As Tom Wambsgans says in Succession, we here for you. All right, folks, here's our next question. A 6-year-old boy is brought to the clinic by his mother due to a 2-day history of fatigue and bluish discoloration of his lips and fingertips. Cyanosis, anybody? The symptoms started a day after attending a family picnic at a countryside park where he drank from a nearby well. Classic. His medical history is unremarkable. There are no known allergies. On examination, the boy appears in mild distress with tachypnea and central cyanosis, but his heart and lung sounds are normal. A blood sample appears chocolate-colored and does not change upon exposure to the air. Lab results reveal a normal pH, partial pressure of oxygen within reference range, but the oxygen saturation is low. Which of the following is the most likely cause of this patient's condition? All right, chocolate-colored blood, right? Chocolate-colored blood, cyanosis. What do you guys think? Okay, so he's been exposed to some oxidizing agents. Normal pH, partial pressure of oxygen, but the oxygen saturation is low. He has been exposed to some oxidizing agents, right? So our answer is C. And yes, you're right. Study partner got it. Methemoglobinemia. This is a condition where the iron becomes ferrous. So you get the 2 to 3. It's like leveled up, right? And that impairs the oxygen delivery. This is the chocolate-colored stuff that does not improve if you give it more oxygen. And also normal PO2, but low oxygen sat tells you this, and it's the well water. It's the ingestion of nitrates. That's an oxidizing agent that is contaminated in water sources, especially in rural areas. It's not defective heme synthesis. That'd be like sideroblastic anemia, porphyria. That's a chronic issue. Impaired oxygen unloading. That's left-shifted oxygen dissociation curve. Proliferation of the mutant erythrocyte precursors. That's like polycythemia vera. And decreased affinity of hemoglobin would be the Haldane effect. Okay, so we have to understand the difference between PaO2, which is the dissolved, and then the oxygen sat, which is the binding. So methemoglobinemia affects the ability to bind and release oxygen. And so it's normal, PaO2, but you just can't bind and release that oxygen. And so it's nitrates, benzocaine, dapsone, sulfonamides, all of that stuff used in pediatric and rural cases. And you have that chocolate-colored blood because the methemoglobin does not carry oxygen well, and that's why you have that little color to it. Okay, chocolate rain. Bottom line, chocolate-colored blood and low oxygen sat indicate methemoglobinemia, likely due to exposure to oxidized agents. Nice, Dr. Kawasami. All right, here we have a 28-year-old man presented to the clinic with a 2-month history of increasing joint pain and stiffness, particularly affecting his hands and his knees. He reports occasional low-grade fevers and fatigue. On examination, he has swelling and tenderness of his phalangeal joints and knees bilaterally. Okay, we have elevated ESR and C-reactive, but negative for rheumatoid factor and anti-cyclic citrinucleated citrullinate peptide antibodies. Synovial fluid analysis from an affected joint shows an inflammatory process with increased white blood cells, but no crystals. Which cytokine is most likely playing a central role in the inflammation in this patient? All right, what do you guys think? So we have symmetric polyarthritis in the hands and the knees, morning stiffness, swelling, tenderness. All that stuff is pointing us toward like rheumatoid. And there's inflammatory synovial. There's increased white blood cells, but no crystals. And there's also negative RF and also anti-CCP. That's seronegative rheumatoid arthritis. So this is some sort of rheumatoid arthritis-like disease with autoimmune inflammation of the synovium. It's just seronegative. And so the pathophysiology here is weird, right? But this is cytokine-mediated chronic inflammation. And this is an interesting question because we have tumor necrosis factor and interleukin-1. So tumor necrosis factor, that's the master cytokine. This promotes inflammation, activates your macrophages and fibroblasts and induce other cytokines like IL-1 and IL-6. It stimulates the osteoclasts. And then there's IL-1, right? And that works with TNF-alpha to increase the synovial inflammation and the cartilage destruction. So really, this question would involve both of these. And then IL-6, this promotes the acute phase reactants. That's increasing the ESR. But here they're saying playing a central role here. So I think we're more partial to TNF-alpha. IL-10 is an anti-inflammatory, so it inhibits the Th1 response. And then IL-2 promotes T-cell proliferation, not primarily inflammatory in rheumatoid arthritis. So the main driver in this cascade is TNF-alpha, because TNF-alpha inhibitors are super important in rheumatoid arthritis treatment and also other issues as well, like etanercept is a TNF receptor fusion protein, and so it's used in rheumatoid arthritis, psoriasis, ankylosing spondylitis, all those. Infliximab is anti-TNF-alpha monoclonal antibody, and that's also used in rheumatoid arthritis, also IBD and psoriasis. And so that's the main cytokine that's kind of responsible for all this stuff. Now, IL-1 is also a really good one because that promotes inflammation, but it's going to act like synergistically with TNF-alpha. It's not the primary driver. Okay, Dr. Kamisami says for the previous question about methemoglobinemia, O2 saturation and O2 content is down. However, HP concentration and PaO2 is unaffected. Yeah, so for methemoglobinemia, the PaO2 is the partial pressure of the dissolved O2 in the plasma, and that's, dissolved O2 isn't affected. The problem is the hemoglobin, right? It's not the lungs. The PaO2 is fine. The hemoglobin concentration is normal. The total hemoglobin amount in the blood is unchanged. It just is chemically altered so that it's 3, instead of 2, it's 3. The oxygen saturation, which is the SaO2, that's decreased, right? It's the fraction of the hemoglobin that's bound to O2. It'll drop because Fe2 can't bind O2, right? So, Fe3 can't bind O2. And so the pulse ox is usually 85%, and they're unresponsive to oxygen therapy. You give them oxygen therapy, it doesn't work. And also the oxygen content is decreased as well. And that's because the oxygen content depends on how both the hemoglobin and its saturation as well. So yeah, that's the lay of the land there. And that's all because the Fe3 plus can't bind to oxygen. And so the functional oxygen carrying capacity is lower. But the remaining Fe2s and hemoglobin have increased oxygen affinity. And so they're less likely to release it. And so they're hypoxic even though PaO2 is normal. You have that chocolate brown stuff, right? Good recap. All right, here is the bottom line. Negative RF and anti-CCP with inflammatory suggest seronegative spondylo, and so TNF-alpha is the key inflammatory cytokine. Or tumor necrosis factor is key for inflammation. All right, a 35-year-old woman is brought to the clinic by her sister due to progressive drowsiness and confusion over the past 48 hours. She has a history of chronic hepatitis C, diagnosed 5 years ago, and she has not been adherent. Her sister notes that she's been frequently disoriented, and now she's confused. She has scleral icterus and several spider angiomata on her upper chest and back. Her abdomen is distended with the fluid wave, and there is tenderness on the right upper quadrant. Neurologic exam reveals positive estrixis. Lab studies show elevated ammonia level. What is the following most likely diagnosis? So the estrixis is the flapping tremor, and that's metabolic encephalopathy. And there's elevated pneumonia, and that's the hepatic dysfunction and CNS effects. So there's hepatic encephalopathy. The trap answers why they're wrong. Alcoholic hallucinosis, that's vivid hallucinations. There's no recent alcohol use. Corpus confabulation and irreversible memory loss due to thiamine deficiencies. Alcoholic hepatitis is that ratio of greater than 2 to 1. Wernicke's encephalopathy is going to involve confusion, ataxia, and ophthalmoplegia. That triad is absent here. Cis is due to the tremor from negative myoclonus due to CNS toxicity. Elevated ammonia is the hallmark. Spider angiomata is from estrogen excess from the impaired liver metabolism. Too much estrogen going on. Fluid wave, portal hypertension. So you're flapping the hands is the sign of the brain poisoning by the gut. It's estrixis. Here's the bottom line. Hepatic encephalopathy is characterized by confusion, estrixis, and elevated ammonia in patients with liver dysfunction, liver disease. All right, next question. We have a 59-year-old woman presents to clinic with swelling in her legs and abdomen. She has history of rheumatoid arthritis and methotrexate. She has periorbital purpura and glaucia. Creatinine level and proteinuria is elevated. Eosinophilic amorphous material, and the Conga red and apple green. So we know this is amyloidosis. We just have to figure out what type. So there's primary, and that's involved in your plasma cell disorders like multiple myeloma. And then there's secondary, which is chronic diseases like infections like tuberculosis, IBD, things like that. And then there's familial, that's hereditary. And then there's senile, which is in the elderly. There's also dialysis related. And there's the islet amyloid, that's type 2 diabetes. And also the atrial amyloid, that's in depositions of the elderly as well. And so now we have to apply all of that to this patient. So they have chronic rheumatoid arthritis, that's chronic inflammation. And there's elevated serum amyloid. And that's an acute phase reactant that's made by the liver. Right? Elevated serum amyloid A, acute phase reactant made by the liver. And that causes persistent elevation. And so you have that misfolding And then you get the amyloid depositions, the insoluble fibrils in the organs, especially in the kidneys. And that leads to proteinuria, nephrotic syndromes, renal failure, all that stuff. And so her amyloid fibrils are derived from amyloid A protein, from serum amyloid A. So I'd say because this is a chronic inflammatory disease, that's going to be pointing more towards secondary, not plasma cell. And in secondary, you have serum amyloid A protein. Whereas for primary, you have the immunoglobulin light chains. So that's plasma cell dyscrasia, multiple myeloma, that kind of stuff. And now, if this patient presented differently, then I could have a different answer. Like if she had heart failure, then you could think of the atrial neuritic factor. Since this one was amyloid A, we know that it's going to be associated with the kidney, nephrotic syndromes, and chronic disease. Beta 2 microglobulin, that's associated with hemodialysis. And the transthyretin, that's going to be more of like a family history associated. So recognizing this is secondary, recognizing secondary goes with amyloid A is important. We'll go on to our next question. All right, we have a 17-year-old male, visits an adolescent health clinic, and he confides he's been sexually active and inconsistent condom use. He's concerned that his parents will know, but somebody else was diagnosed with an STI, and indeed it's gonorrhea. So he's diagnosed with gonorrhea, and he requests confidentiality. And so this is a minor with a sexually transmitted infection who is capable of understanding his condition. And so confidentiality and minors in sexual health. In the US, minors have a right to confidential diagnosis and treatment for sexually transmitted infections, contraception, pregnancy, substance use, and also mental health. Confidential. And that means that parental consent is not required to test or treat an STI, and the provider can maintain confidentiality unless there's some sort of risk of harm or abuse. And so the next step is going to be confirming the gonorrhea. So you got to treat the infection with ceftriaxone and also doxycycline, especially if chlamydia is not rolled out. And you educate the patient, you say, hey, you got to have consistent condom use and also partner notification and treatment as well. So you got to avoid sexual activity until the treatment is complete. And so conduct a discussion about safe sex and the importance of informing sexual partners. Now, A, insist on obtaining parental consent is not necessary because, as we discussed in the US, this is one of those conditions. So don't tell mom, tell the partners. So yes, discuss the safe sex practices and partner notification after confirming Neisseria gonorrhea in sexually active adolescents. All right, here we have a 3-month-old infant brought to the pediatrician by her parents due to persistent diarrhea and recurrent respiratory tract infections. They report that their daughter has been hospitalized twice for pneumonia since birth. That's a lot. Child appears thin, signs of dehydration. Evaluation reveals a profound lymphopenia, and we show accumulation of DATP and a deficiency and lymphocyte DNA synthesis. Which of the following enzymatic deficiencies is most likely responsible for this? You can see it's highlighted. Adenosine deaminase deficiency is what's going on. This is profound lymphopenia in patients. So this is SCID. Down on Skid Row. Elevated DATP points directly to this. So they have the severe immunodeficiency, recurrent infections, diarrhea, lymphopenia. That's all hallmark of this. Adenosine deaminase deficiency is going to be associated with SCID. It's essential for purine metabolism. And so without it, you have the toxic levels of DATP. And so you get apoptosis of T and B cells causing profound lymphopenia. What about the others? Purine nucleoside phosphorylase deficiency. That would be a T cell deficiency only. Adenine phosphoribosyl transferase deficiency would cause hyperuricemia. Hypoxanthine HDPRT would have self-mutilation. Xanthine oxidase, renal stones not linked to immune defects. SCID's life-threatening. DNA synthesis associated, DATP buildup. Bottom line, adenosine deaminase deficiency causes severe combined immunodeficiency leading to lymphopenia and recurrence infections at birth. All right, here we go. A 55-year-old man presents to the emergency department after experiencing sudden onset of weakness and coordination difficulties. His wife reports he's been complaining of double vision earlier that day. On examination, the patient exhibits weakness of the right upper and lower extremities and increased muscle tone and brisk reflexes on the right side. He's got ptosis, mydriasis on the left eye, and it's down and out. What do we got? All right, right-sided weakness, hyperflexia, spasticity, and so we have contralateral to the brain lesion. So the left corticospinal tract is going to be involved. We know that for sure. And he's got the down and out. So he's got ipsilateral, it's the left side. Ocular motor, that's cranial nerve 3, palsy. And there's a lesion on the left midbrain. That's where the cranial nerve 3 exists. And so there's a lesion on the left midbrain, especially basis, so the crus cerebri. That's Weber syndrome. It's a type of a midbrain stroke. And so there are some findings. Usually the corticospinal, let's say it's on the left side, would cause contralateral hemiparesis, so right-sided weakness. Also the cortical bulbar findings, they're going to be damaged on the left side. And so the finding is going to be contralateral lower facial weakness. And sometimes that's going to be seen in this patient, it was contralateral facial weakness, which I guess they actually didn't mention in this. But the corticobulbar findings are going to, if it's on the left side, cause contralateral lower facial weakness. And then ocular motor nerve, if it's on the left side, you'll have ipsilateral cranial nerve 3 palsy, so ptosis, mydriasis, the down and out look. So the question's saying there's increased tone in burst reflexes on the right side. So there's corticospinal involvement and there's a left cranial nerve 3 palsy. So that means there's a midbrain lesion on the left side. All right, so what about this one? Hyperacusis of the left ear. That'd be a facial nerve lesion. And so facial nerve would be involving the pons, not the midbrain. Loss of pain and temperature sensation on the left side of the face. That'd be like a spinal trigeminal nucleus lesion. Lateral medulla and pons are associated with that. Ataxia of the left arm. Here, this is pure hemiparesis. Cranial nerve 3 palsy, so it's Weber syndrome, not that. Loss of proprioception and vibration sensation on the right leg. That's the medial lemniscus involvement, so contralateral dorsal column pathway. And then the weakness of the left lower face, be ipsilateral. And so our answer is a D, because you have the medial lemniscus involvement, contralateral dorsal limb. You have the loss of proprioception and vibration on the right leg. Because the lesions are happening in the left midbrain, so Weber syndrome with a medial lemniscus involvement is what's going on. And there's damage to the corticospinal tract, there's corticospinal weakness, and also damage to the medial lemniscus, and that causes contralateral loss. So here we go. Weber syndrome, right-sided spastic weakness, down and out. Hyperacusis is facial. Loss of pain and temperature is the trigeminal nucleus. Ataxia cerebellar. Lesion associations there. Weakness of left lower face. Corticobulbar tract. There's no facial weakness in this one, actually. No facial weakness in the stem. So it's the midbrain. Makes the eye go down and it paralyzes the opposite side of your body. Oh, 20 push-ups. All right, let's do 20. Let's do 20. I need an animation to play. Good call. Here's the bottom line. Right-sided weakness with left eye ptosis suggests right midbrain stroke affecting the corticospinal and sensory pathways. Push-up time, folks. It's push-up time. Oh, and then we got 3 more questions, and then we're have a break. The zones of the open sea. Oh, yeah. Here we go. 2, 5, 6, 7, 8, 12, 14, 15. Easy work. Oh, yeah. I needed that. Thank you. Oh, after so many hours of sitting down, you're like, it's good to get the blood flowing again. So a 35-year-old woman presents to the clinic with a 3-day history of watery diarrhea, abdominal cramps, and mild fever. She returned from a trip to Southeast Asia a week ago where she enjoyed various street foods, and she's now got non-typhoidal salmonella. And this isn't fair. I'm going to tell you why in a second. This isn't fair because I haven't given you all the answers. Do you want another answer, or are you fine with just these 4? What if I said the other answer was prolonged fecal carriage of the organism? Would you choose it then? So she's been eating the food in the streets, right? And we know it's non-typhoidal salmonella. And so she's got watery diarrhea, stable vitals, she's hydrated, and this is a self-limited case. And so they're asking about antibiotics. And so let's say option E is prolonged fecal carriage of the organism. What we need to know for this one is about non-typhoidal salmonella, because this is caused by Salmonella, oh geez, what's the name? Typhimurium. Still A or B? Are you sure? Okay, we'll break this one down for sure. And so basically you have undercooked poultry and eggs and contaminated food and water. And so it infects the intestinal mucosa and you have inflammatory diarrhea is what's happening in this girl. And usually this type of salmonella is just going to resolve on its own. Usually it's within 4 to 7 days and you're totally fine again. Oh man, do some good stretching. And so antibiotics are not routinely given actually for this particular case because in immunocompromised adults with mild disease, antibiotics aren't recommended because they don't shorten the illness duration and they prolong the bacterial carriage in the intestines and the stool. And so they remain a long-term carrier and they can transmit the infection to other people. So the answer is E. And the reason I couldn't tell you is because they bolded it, right? So it doesn't shorten the duration. Now let's talk about the other ones though, because there's some good distractors as well. So like C. diff, increased risk of C. diff infection. That's possible with many antibiotics, right? Many of them, but not the most characteristic risk in this patient, just because with salmonella, it's going to be the fecal association is super important. And so I like that answer choice. It's a good one and it's really buzzy. And so I can see why you picked it. Antibiotic resistance, that's general, right? And so that's also another good answer. There are a lot of really good answers to this one, but it's a little bit too general, especially when compared to E, which is very, very specific to this particular condition, because this is what happens when you give antibiotics to salmonella gastroenteritis. So this is just uncomplicated non-typhoidal salmonella. Antibiotics are avoided because they don't even shorten the illness and they prolong the intestinal carriage of the bacteria. Yeah, very tough to logic through for sure. Yeah, you want me to explain E more? Let's see if there's a better explanation down here. Okay, so the best way to explain it is the carriage, that just means that the person continues to harbor the pathogen in their body, even though they don't have any signs of it. And so in this particular case, salmonella bacteria remains in the intestines and it keeps being excreted in the stool long after. And the way this happens is usually after there's an infection, after the infection clears, the immune system in the gut microbiota eliminates the pathogens. So the infection's gone and now the the immune system in the gut eliminates it. Antibiotics, however, disrupt that normal gut flora. And so now the Salmonella finds a niche to persist, right? Because it's the immune system in the gut eliminate this pathogen after it's cleared. And it's going to be cleared in 4 to 7 days. And normally the gut is like chomp, 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 chomp. Antibiotics disrupt that normal gut flora. And so the Salmonella finds that little place. It's like, hey, I'm going to keep going. And so that allows the bacteria to survive and also be shed for weeks to months, sometimes even years. Yeah, exactly. Same mechanism for original pathogen. And so they feel healthy, but they're still shedding the bacteria in the stool, and that can cause outbreaks if the hygiene is poor. That's why we avoid antibiotics in non-typhoidal Salmonella infections, because they can turn an acute infection into a chronic carrier state. Does that make sense? I wonder what else this thing says. Here's the pathophysiology. Invades intestinal mucosa through the M cells in the Peyer's patches. You have an inflammatory response, and antibiotics disrupt the microbiota, reducing the competitive inhibition, longer persistence, and then you can spread it to everybody else. Here's the bottom line. Antibiotics are no-go because you can prolong it. All right, so this one's actually pretty easy, but we'll wait for the questions to load. Yeah, you actually gave me this vignette, didn't you? That's funny. Okay, sounds good. Thanks for withholding the secret. So we got a 22-year-old woman, got some dizziness. She's a collegiate runner, athlete, systolic murmur, best heard on the left lateral sternal border of the apex, and increases when she stands quickly. That's interesting, right? Because that normally shouldn't happen. Her father is also diagnosed. So this is like the world's most buzzy question ever. There's a murmur that's increased by standing and decreased by squatting. And so that's some sort of an outflow obstruction. And there's a familial link. What is the answer? I know that hematopoiesis knows this. Okay, so this is hypertrophic cardiomyopathy. Alrighty, so she's got it. All right, there you go. So yeah, like the sudden death change there is good. It worsens with decreased preload, the sudden death in young athletes. So hypertrophic cardiomyopathy is suggested for systolic ejection murmur that increases with standing and decreases with squatting. There you go, folks. On to 149. 2 more questions, then we're done. And we have a little break. Then we have a break. So for this one, we have a 28-year-old man. What happens immediately after he stands? So standing will definitely cause a decrease in venous return, right? Okay, so hematopoiesis is saying, I don't know, but the stroke volume would reduce. Okay, so I like that. Decreased stroke volume. What happens to the heart rate? So there's a 28-year-old man. You're saying C is most likely, and C is correct indeed. So the baroreceptors are going to detect, they're like, oh my gosh, that blood pressure is low, and they're going to stimulate the heart rate to compensate, to maintain the perfusion. So the answer is indeed C. Heart rate increases, it's compensatory. Frank-Starling mechanism, you knew this, that the stroke volume decreases. There's a baroreceptor reflex, the decreased pressure sensed by the baroreceptors, increasing the sympathetic tone. And the sympathetic compensation, the heart rate and the contractility, it needs to increase the heart rate and the contractility to maintain that same cardiac output. Right? We have to maintain the cardiac output. And so the stroke volume the cardiac output is equal to the stroke volume times the heart rate. And so we have to maintain it. And so what needs to rise is the compensatory contractility and heart rate. Most commonly in the elderly, yeah, you got it, hematopoiesis. So when you're standing, you have decreased venous return. That causes decreased stroke volume. That causes a baroreceptor reflex, and that causes the heart rate to increase to maintain that cardiac output. Because you can't change, it's like primary low volume is a way to think about it. And so you have to maintain that cardiac output. And so you have to, the secondary kind of compensation for the heart rate is a good way to think about this. So upon standing, heart rate increases to compensate to decreased stroke volume due to the orthostatic hypotension. Hey, Sidal, how's it going? Yeah, you guys got it. Nice. I love the chat discussion that's happening here. This is nice. All right, you guys ready for the last question of this until we have a little break? All right, so 62-year-old woman, she's vomiting a lot. She had a stomach bug, and now look at that, 85 over 55 is her blood pressure. And BUN is 24-1. Okay, so she's vomiting, and that means there's a loss of tons of fluids and also electrolytes. And so now she's hypotensive, and she's also tachycardic. She's going, that's 130 a minute, right? And so that's hypovolemic shock due to volume depletion. Right? The lab clue as well of this 24-1, this is pre-renal azotemia. So that's hypovolemia due to increased urea reabsorption by the kidneys trying to conserve that water, trying to conserve the water. So there's lower blood volume and there's lower venous return and there's lower cardiac output, right? Lower cardiac output. And there's low tissue perfusion, there's tissue hypoxia. And that means tissue hypoxia is what's happening in this person. Now, there are compensatory mechanisms whenever we have tissue hypoxia. There's an increase in sympathetic tone, right? And so the heart rate is going to go up. You're going to have vasoconstriction. You're going to have renin-angiotensin-aldosterone syndrome is going to be activated. You're going to have increased of antidiuretic hormone, right? So this has to be increased. Agreed? So let's analyze these are the parameters. We have arteriovenous O2 difference, okay? That is going to be increased, right? Or O2 difference. Because the tissues extract more oxygen because of delivery, blood flow is low. And so you have to extract more, right? And so there's a wider difference. Okay, so that's going to be increased. What about the plasma lactic acid? Well, that's also going to be increased. The reason being there's poor perfusion, right? And so that causes anaerobic metabolism, and anaerobic metabolism increases the lactic acid in the plasma. Okay, that should make sense. There's ADH obviously increased. And then systemic capillary fluid transfer is also going to be increased as well. You're going to have, I think it's a good question too. Good one to end on for this stream, at least until we take a break. So increased reabsorption. And so you have decreased hydrostatic pressure. It's not pushing as much as it otherwise would. So the fluid is moving from the interstitial to the capillary. And so the Starling forces favor reabsorption because you're trying to preserve that volume. You're hypovolemic. So you're preserving the volume. So there's reabsorption. ADH, reabsorption. Lactic, you don't have that oxygen. And so you do lactic acidosis, right? So your lactic plasma goes up. And there's that big old difference because you have to go chomp up that oxygen. Hopefully that's a decent explanation. I used a lot of sound effects. And so the answer to this question is C. Increase reabsorption. There's an explanation. We kind of already talked about most of the stuff. Hypotension, tachycardia, BUN 20:1 is prerenal. All right, guys, there we have it. Hypoperfusion, tissue hypoxia, increased difference, all that other stuff we talked about. And here's the bottom line. Increased BUN to creatinine ratio indicates prerenal azotemia due to dehydration and likely increased plasma ADH and lactic acid. If you guys found this helpful, please be sure to like and subscribe. I'll be editing these now. We have 50 questions to go. So like, subscribe, hit the bell so you can be notified when those come out. Hopefully you guys have an amazing rest of your day. And now for the rest of you guys on Twitch and YouTube, time to take a little bit of a break, but don't go anywhere yet unless you do want to just go somewhere. We just borrow from the Federal Reserve. Okay, that's my tune from Toontown, by the way, if you want to know what that is. The chicken dance. Oh, people on YouTube can't see the emoji. That's sad. Okay, here we go. Gotta refresh this real quick. There you go. Should see it now. Hey, Hematopoiesis, thanks for the T1. I've got to make some really cool animations, by the way, for subscriptions, because right now it doesn't do anything. Thanks for the tier 1, Hematopoiesis. Really appreciate it. Okay, do you want to take a stab at this question now? Now that you have the no ads? Thanks so much. Nice. Phototoxic due to tetracyclines. Nailed the question too. My guy. Well done. All right, so in this question, as Hematopoiesis said, we have a 25-year-old woman, intense redness, pain over the lower legs, and she was at the beach the previous day, several hours in the sunlight, and she's on doxycycline. And so she has a phototoxic reaction. Very nice, quick, easy, beautiful. Vesicular arithmetic skin lesion, classic setup here. Allergic contact would be nickel poison ivy new soap. Chemical burn is associated with an accidental spill or some sort of a chemical exposure would be mentioned, which it wasn't, obviously. Mallar rash, DS, antibody, butterfly-shaped, mallar rash, lupus. And then psoriasis has that silvery scale on the extensor surfaces. Nailed that one, 100%. Okay, here's the bottom line. Phototoxic reaction is likely due to doxycycline and sun exposure, causing erythema and vesicular lesions. I think what I'll do now is I will put the questions up so you guys can see them, but then I'll wait until all of the diagrams load so that YouTube can have the full experience. Good intuition, Hematopoiesis. I love this train of thought. This is really awesome. And definitely feel free to lay bare whatever you're thinking. It really helps the stream and the quality. Sounds good. I love the guess. Really, really good. All right, so there's a 67-year-old woman with a history of hypertension and atrial fibrillation, and she's undergoing a post-operative recovery after cardiac surgery. And now she's got rapid palpitations and is found to have a heart rate at 180 beats per minute. The medical team decides to administer a medication for rapid control of her heart rate, which can be quickly adjusted as needed. Which of the following medication is mostly appropriate? A lot of beta blockers. Okay, so quickly adjusted is Esmolol, is an ultra short-acting beta blocker for rate control. Super good for rapid titration and acute arrhythmia management. So Esmolol is used in acute settings because of its extremely short half-life. It's like 9 minutes, very, very short. And so that allows a very precise control of the heart rate. And you administer it through, so it quickly titrates and it makes it super good for post-operative supraventricular tachycardia and also atrial fibrillation or SVT. And so this patient is hemodynamically stable, but they have dangerously fast heart rate. And so Esmolol is going to provide rate control without prolonging the beta blockade. Atenolol is longer acting, atenolol, and carvedilol is for chronic heart failure, and that's a mixed alpha and beta. This is a mixed alpha and beta. And labetalol, which was one of the answers that you guys mentioned there, that is used in hypertensive emergencies. And yes, it's available IV, but it's mainly used for blood pressure control, not for heart rate and arrhythmias. All right. And then carvedilol, it's for chronic heart failure mixed. And oops, I highlighted Esmolol, but I meant carvedilol. And amiodarone, that one is for an antiarrhythmic for refractory or unstable arrhythmias. So it's antiarrhythmic and it works very, very slowly for rhythm control and it's not for rate. Okay, so not for rate. This is a rhythm control. All right, so that's the lay of the land there. You have surgical stress in this patient that causes a sympathetic surge and atrial irritation. Then you have increased automaticity, so you have ectopic foci that are firing rapidly in the atria. And then there's AV node that conducts very rapidly, causing like an SVT, supraventricular tachycardia, or rapid AFib. And then you have short-acting beta blockers like which then slow that AV node conduction. And there's rapid rate control without the long-lasting hemodynamic suppression. All right, so like 30% of cardiac surgery patients develop some sort of an arrhythmia during recovery. And so we got a 67-year-old, she's got SVT 2 days after surgery. And so she's in that demographic. And the rhythm is super fast, but she's stable. And now we're like, hey, we got to slow that heart rate as quickly as possible. So esmolol is just a beta-1 selective blocker with a super short half-life. Esmolol, E for extremely fast. And now there's also this alphabet mnemonic, right? There's an alphabet trick. A through M, these guys are just beta-1 selective blockers. And then N to Z, these guys are non-selective. Non-selective for N, non-selective beta blockers. So it's beta-1 and beta-2. And so A through M, that primarily acts on the heart, B1, right? Beta-1. And that makes them safer in asthma and COPD and better for rate control. So atenolol, bisoprolol, esmolol, metoprolol, right? All these lols, right? They're used for supraventricular tachycardias, but esmolol is the fastest acting. So post-myocardial infarction patients, they are just beta-1. The non-selectives are the heart and the lungs, right? Non-selectives are the heart and the lungs. And so they're going to be used for not ideal for asthma and COPD due to their bronchoconstriction risks, like nadolol, propanolol, timolol. Those are used for portal hypertension, like propanolol, and essential tremor as well, and migraine prophylaxis, and also thyroid storm. And hopefully you guys can see there, hematopoiesis just left a recapitulation on what we discussed. You're definitely hitting on the points there for sure. So esmolol, you should think of as beta-1 selective, ultra short acting, used in SVTs, is beta-1 selective. And that one has oral and IV moderate onset. So yep, esmolol is for an emergency. Carvedilol carves down the afterload. Labetalol lowers with blood pressure in labor. Atenolol is long acting. I don't know. Nolol, I don't know. Whatever memory drugs get you there. But yes, you got the ideas. Here's the bottom line, folks. Rapid control esmolol. AEOlol. Nice. Adol. Beta adrenergic blockers. AEI-lol is mixed. Nice. Okay, this question is actually wrong, but maybe it'll be helpful to do it anyways, and we can talk about the mechanisms. Okay, so in this question, it says there's a 2-week male, which is why I take umbrage with this question, because this is impossible. But they prevented the pediatrician for a routine checkup. The parents expressed concern about a soft, non-tender swelling on the left side of their neck. And like you guys are saying, what this is, a cystic hygroma, yeah? And so on examination, the mass is compressible and transilluminates brightly. The child has puffy hands, and cardiac examination has crescendo, decrescendo, systolic murmur, best heard at the upper right sternal border. And so we have this analysis, which of the following conditions is most likely responsible for these symptoms. Okay, so we have a transilluminating neck mass, which means that it's going to be a cystic hygroma from lymphatic malformation. And there are puffy hands and feet, and also heart murmur, right? And so this question is wrong because it can't be, it's Turner syndrome, but it's in a male, right? And Turner syndrome cannot happen in a male. So it's 45X, which is phenotypically female. And so it's wrong. Maybe what happened, let's just try to massage this into existence here. What if in real life, sometimes infants with ambiguous genitalia are assigned male at birth? So Turner syndrome could be discovered after genetic testing. So maybe they're just testing your knowledge on syndrome features over the assigned gender. But yeah, wide space nipple, streak ovary. Yep, that's really buzzy for it as well. And you have rare mosaicism, maybe, but that's like for true intersex condition. But yeah, you're right. Like there's no sense in massaging this like crazy. But the bottom line here is if you see cystic hygroma and lymphedema and bicuspid aortic valve murmur, then it's Turner's or Turner's variant. That's what takes precedent. And so you do a chromosomal analysis. Maybe that could be like, hey, let's do a chromosomal analysis. Are you sure this is a male? But yeah, I don't like this question for that reason. But I did preface beforehand that it's a little bit off. But hopefully this is still beneficial in recognizing the cystic hygroma associations with Turner syndrome. Lymphangiomas, or the cystically dilated space, it's filled with the lymph fluid. Okay, kind of fun. Kind of tricky, kind of quirky. Here, hematopoiesis. Why don't you do exclamation mark, IV tutor, space, and then type your question. I want to see if it works. There it is. Maybe I can make that even more concise. Yeah, I'll work on that prompting. Hopefully the tutor will be more efficient in the future. What do you guys think for this one? So here we have a 52-year-old woman presenting to the clinic with a 6-month history of persistent cough and hoarseness. She reports her symptoms are worse at night, and occasionally she wakes up with a sore throat. She also experiences a burning sensation in the chest and acidic taste in her mouth. Obesity, type 2 diabetes. She denies smoking or alcohol use. Physical examination, her vital signs are within normal limits, despite the use of over-the-counter antacids. Her symptoms persist. Upper endoscopy reveals hyperemia and mild edema of the lower esophagus. Biopsy of the esophageal mucosa shows basal cell hyperplasia, elongation of the lamina propria, and eosinophilic infiltration. What is the diagnosis? We're thinking B or C. I like the discussion here. This is good discussion. And there's like 1 in 5 of adults in the US have GERD symptoms. So here she's got some GERD symptoms: burning chest pain, sour taste, hoarseness, cough, worse at night. She's got reflux problems. Endoscopy is showing erythema. And so the biopsy has basal cell hyperplasia, elongated papillae, and also eosinophils. So this is reflux esophagitis. So it's not candidiasis, right? The histology is exactly what we would expect from chronic acid reflux. And the pathophysiology here is important. You have lower esophageal incompetence and also transient relaxation, right? And then you have chronic injury over time, which causes the metaplasia, which then leads to an adenocarcinoma risk. And so heartburn, regurgitation, cough, and hoarseness, all that stuff. All right. And then regarding all the comments there, you're asking, does reflux esophagitis show eosinophils? Yes, it can. There are some differences though. Right? Eosinophils are present. They can be present in both, but reflux esophagitis has scattered and mild presence of eosinophils, whereas eosinophilic esophagitis is dense and it's layered and it's patchy. And on histology, you have eosinophilic microabscesses and degranulation in esophageitis, eosinophil esophagitis, but in reflux, you have basal cell hyperplasia. And so that really keys you into the diagnosis of reflux esophagitis, is that basal cell hyperplasia and the papillae elongation. Clinically, you see this in older adults, and then younger males would be more eosinophilic. And then in an endoscopy, you have the rings and the furrows in eosinophilic, and hyperemia and edema are going to be seen in esophagitis. And the location is different too, because, well, they can both affect the esophagus, right? But in eosinophilic, it's often the proximal or it's more diffuse. And also, one more important difference here is that how they respond to PPIs. Reflux esophagitis responds really well to PPIs, whereas philic esophagitis is characterized by eosinophilic infiltration, is often associated with atopic conditions. And I might have to go after this one because I realize I have to get my flu shot. I still have not got my flu shot yet, so I forgot I had to do that today. So I might go head on over to like a Walgreens and make that happen for myself. Don't worry, hematopoiesis, we'll be back. If not like immediately back when I get back from getting my shot, then we'll be back either later tonight or tomorrow as well. And we'll hit all of these though. Yeah, big sad. Okay, let's do this. Let's finish 10. So 5 more after this, and then we'll call it like another little break here. So here's our next practice question. Boom, shaka boom. 30-year-old construction worker presents to the clinic with pain and weakness in his right arm. Yeah, let's go. He mentions that he tried to catch a falling metal pipe with his right hand. See, that's where he messed up. Since then, he struggled to lift objects and twist his forearm. There's noticeable swelling and bruising of the anterior part of his upper arm. He demonstrates difficulty with his forearm supination and elbow flexion against resistance. Okay, against resistance. That right there should tell us our answer. What is it? What do we got? Difficulty with forearm supination and elbow flexion. Okay, so add the anterior arm bruising and the lateral forearm sensory loss. It's going to be the biceps. Yes, the biceps and brachialis and sensory to the lateral forearm. All of this is super duper musculocutaneous. You guys are too smart. Can't trick you up. You got it. Biceps tendon rupture injury leading to damage of musculocutaneous nerve, innervating the biceps brachialis, and choriobrachialis. Hundo P. You got it. Axillary deltoid paralysis, median, apan, carpal tunnel associations. Radial has wrist drop. Ulnar has the claw, hand, and loss of sensation in the medial fingers. All right. You have to know the C5, C7, musculocutaneous, elbow flexion for the biceps and forearm supination in the biceps. And here we go. Here is our bottom line. Musculocutaneous nerve injury causes weakness of the elbow flexion and forearm supination, often after trauma to the upper limb. All right. That's some good stuff right there. That is some good stuff. Ooh, we got a challenge. We got a question about this question back at me. What special exam for biceps tendon rupture? Okay. Popeye sign? I don't know. Did you have something in mind? Is it the hook test? You go like this, you tell the patient to flex their elbow to 90 degrees, and then you supinate the forearm. Is that what you do? The speed test. Oh yeah, the speed test. That makes sense. That's for the long head of the biceps tendon, right? That's like the hook test, except like you tell them to put their palm up. So they flex their shoulder to 90 degrees and then they put a palm up and they extend their elbow, right? There are a couple of these to test different things, but either pain or rupture. Okay, nice. That's a good question. All right, on to our next one. Here we go. So a 52-year-old woman presents to the clinic with a 3-week history of dry cough and mild exertional dyspnea. She was diagnosed with heart failure with reduced ejection fraction and started on new medication. Now she's on furosemide, carvedilol, spironolactone, and also an antihypertensive. Her vitals are within normal limits, and her chest examination reveals clear breath sounds bilaterally without crackles and wheezes. Which of the following most likely explains her symptoms? Hematopoiesis, lisinopril ACE inhibitor. Nice. Switch her to Narvan, she'll be okay. This is really, really good stuff. Yep, lisinopril. Nailed it. ACE inhibitors and dry cough. So bradykinin builds up in the lungs, causes irritation, dry, non-productive cough. Lisinopril is an ACE inhibitor, most likely the cause of the dry cough. They present the breakdown of bradykinin, which is a vasopeptide. Increased bradykinin leads to persistent dry cough. All that bradykinin causing that coughing. Switch them on over and she'll be okay. I love it. There we go. The ARB, that would prevent this. Same thing with this guy. Amlodipine causes peripheral edema. Digoxin, positive inotrope, arrhythmic risk, a risk of arrhythmia. Okay, bottom line. Newly added amlodipine can cause cough and dyspnea due to peripheral edema. Amlodipine? I should say lisinopril. Okay, ignore that. Basically, we switch her to Narvan, she'll be okay, like hematopoiesis said. Sorry, guys. Sometimes the AI lets me down. Pretty frequently, actually. Okay, so we just jump to the very end for this one, and we read, what supports the diagnosis of inflammatory bowel disease over irritable? Well, inflammatory bowel disease, that's structural and it's systemic disease, and so you have things like anemia and weight loss. Whereas the pain being relieved here, IBS is just a functional disorder with no inflammation or systemic symptoms, right? So none of that. That's all IBS. Soon we'll be letting the AI down. That's funny. Very soon. It's already happening. Okay, the postprandial, that's postprandial bloating is going to be definitely with some IBS, but this is also non-specific. Yeah, so this is common in both the bloating, constipation, the pain and stuff. But the anemia and weight loss, that's actual, legit, true mucosal inflammation kind of thing. Those systemic findings in the labs. Bottom line, anemia and weight loss strongly indicate inflammatory bowel disease over irritable bowel syndrome. All right, so this is the same exact question. And so the presence of the blood in the stool could be another example there. Metagesia, blood in the stool, points to IBD. Crohn's or ulcerative colitis. Metagesia in 65 is colon cancer unless ruled out otherwise. Nice. Okay, 8, 9, 10. Let me take a break. Go to Walgreens, get my shot. No, flu shots don't give you autism. No. You hate to see it. 67-year-old man is brought to the emergency department with a sudden onset weakness in the right side of his body and difficulty speaking. A history of hypertension and hyperlipidemia, but is otherwise healthy. On examination, he is alert, but aphasic, with a right facial droop and right-sided hemiplegia. On contrast, CT shows evidence of an acute left middle cerebral artery. The underlying mechanism of neuronal injury is primarily due to excessive stimulation of certain receptor, causing accumulation of the calcium. Which intervention would most directly mitigate this mechanism of injury? Calcium. We actually went over this recently, if you guys remember. We talked about this one, antagonism of the NMDA. So excitotoxicity is the main primary mechanism of neuronal death and ischemic stroke. NMDA, antagonism, ischemic stroke. So it's the neurotransmitter. Ischemia causes ATP depletion. And so then we depolarize the neurons, causing excessive glutamate release in NMDA and AMPA receptors. And these are overstimulated, and you get large amounts of calcium, activating proteinases, lipases, and nucleases, causing cell death. NMDA in the back garden of her parents' house. Glutamate, gated calcium channel. Glutamate. Okay, ischemic stroke, the blood flow to the brain is cut off. And no ATP, the ion pumps fail, and sodium rushes in, and water follows, and the neurons swell. Calcium overload causes the apoptosis and necrosis. NMDA blockers are potential neuroprotective events. Okay, on to our next question. Oh, but first we have a question from Seidal himself. Seidal asks, which drug is given to prevent vasospasm after a subarachnoid hemorrhage? Ooh, good question. Nimodipine. That's the one that crosses the blood-brain barrier. Okay, let's do this question, shall we? 35-year-old woman with a history of panic disorder, prescribed lorazepam. Medication acts by enhancing inhibitory effects of the neurotransmitter in the central nervous system. Which of the following descriptions best explains the mechanism by which lorazepam acts in the neurotransmitter system? Ooh, we talked about this one, right? Benzodiazepines like lorazepam They're enhancing the activity of GABA A. So GABA A. You thinking D? Dr. Sasson says D. Augmentation of chloride with postsynaptic through the receptor modulation. You are indeed correct. This is GABA A, right? Lorazepam. This is D. So lorazepam is a benzo that potentiates GABA A into ligand-gated chloride channels. And so it opens the channel and allows chloride influx. Okay. Activating the channels would cause excitation. That's the opposite. An atropic chloride channel. Benzos increase GABA A receptor activity, causing hyperpolarization, and it has sedative effects. Flumazenil is a benzodiazepine antagonist that's used in overdose, and alcohol acts on the GABA A's as well, causing downregulation and withdrawal. Okay, open those channels, get that calcium influx, hyperpolarizing, causing increased opening, and you have the sedative effects, anticonvulsive effects. There's the bottom line. Lorazepam. GABAergic activity by augmenting chloride influx in postsynaptic membranes. Hey guys, last question before I go get my flu shot. Let's see if we can get everybody to respond to this one. Here we go. Everybody in the YouTubes and the Twitch, we're all going to come together and try to answer this question here. And going to make it a good one. You got a surprise? Okay, I'm excited. I am excited for the surprise. Okay, here we go. This is going to load, but I hope that I don't get flagged by the AI generating algorithms that I'm using because, well, you'll just read this and find out. Oh, okay. On examination, there is a tender bluish purple nodule at the anal verge. So hopefully it's not too graphic when it depicts this. If it is, I'll have to switch scenes. But there's a 30-year-old man. Emergency department has severe pain in the anal region. The pain is constant, throbbing sensation that began earlier in the day and has worsened with movement. He denies anal bleeding, but reports some itching and discomfort for the past few days. He has no significant past medical history, and he reports engaging in receptive anal intercourse. Yeah, I'm really glad that these are being blacked out over there. Okay, good. Good. Nothing crazy. So what's going on here? Is this a hemorrhoid? Do we have a hemorrhoid here? Sudden onset anal pain. And it's a vascular issue, right? That tells you there's not like an infection or a viral thing. Metapoiesis had a patient with this a week ago. Fun day for you. Yep. This is a hemorrhoid. Severe anal pain, tender bulging stuff, the blue stuff. And so we use analgesics and steroids. And so exact presentation minus the intercourse. Wow, that's crazy. External hemorrhoid is the answer. Hematopoiesis is correct. External hemorrhoids are dilated branches of the inferior rectal vein located distal to the dentate line. Distal to the dentate line. When thrombosed, they present with a sudden onset, exquisitely painful, bluish-purple perianal nodules. The pain worsens with pressure or sitting and often follows straining or trauma. No, 20 push-ups. All right, we'll do 20. I'll do 20. Unlike internal hemorrhoids, which are painless, external ones are highly innervated. Internal is painless. Anal fissure has the pain with defecation. There's no tearing pain here. Perianal abscess, red, warm, fluctuant mass. Human papillomavirus infection, cauliflower-like, painless. Skin tag, soft and painless, fleshy outgrowth. Okay, straining constipation trauma increases the venous pressure, causing hemorrhoid formation. Elevated venous pressure dilates the venous plexus around the rectum. Thrombosis in external hemorrhoidal veins causes the acutely tender, palpable mass. Resolution can be spontaneous. All right. So just the last thing about hemorrhoids, they're the swollen veins in the hemorrhoid plexus of the anal canal. So they're like varicose veins, but for the anus due to increased pressure. And there are two types that occur above the dentate line and then below. Internal is above, below is the external. And the externals are painful because, you know, they innervate the somatic, the pudental, right? And then the internal is the visceral, autonomic stuff. And the internals bleed, but they rarely bleed if they're on the outside, external. And so it's just the increased venous pressure and venous dilation and hemorrhoid formation. So you're straining during defecation, right? Prolonged sitting also can cause this. Obesity, low fiber diet, heavy lifting, all that stuff can kind of cause this. It's the pressure, the pelvic pressure, the venous pooling, and all that stuff. So here is the bottom line. Severe anal pain with tender bluish purple nodule suggests perianal abscess. All right, guys, hopefully you enjoyed this live stream. I have to go to Walgreens to get a shot. Be sure to like and subscribe if you found value in this. I appreciate the T1 subscription from Hematopoiesis and also the push-up reimbursements. I will admit that the former is a welcome present, but I will definitely do push-ups now. But thanks, and we'll see you guys in the next video. Here we go. Hi, Dr. Moise. Good to see you. Thank you. Very nice of you. Nice work, it all. Hopefully that block went well. Okay, guys. Ready to do some questions? Okay. So here we go. We got 40 questions or so to do. So here's the first one. A 35-year-old woman, history of well-controlled type 2 diabetes, presents to the emergency department with confusion, sweating, and palpitations. She is found unresponsive at her workplace, and now her glucose is really low. She's given oral glucose gel, and her symptoms improve. Later that day, the blood glucose is 200. What's the mechanism for rebound hyperglycemia? Blood glucose is going up. So originally she has her hypoglycemia, and then it goes way up. So what's happening is the hypo turns into counter-regulatory hormone responses. So you get cortisol, epinephrine, glucagon, and that leads to rebound hyperglycemia. And that is known as the Somogyi effect. The Somogyi effect. And so our answer is going to be increased gluconeogenesis because of that hypoglycemic phase. Here's the explanation. Their hypoglycemic state triggers a stress response, and that tells the body, hey, we need more gluconeogenesis. And so this is the Somogyi effect. Would it be decreased renal glucose reabsorption? That's what the SGLT2 inhibitors do. How about inhibition of gluconeogenesis? What inhibits gluconeogenesis? That'd be insulin and metformin. That would prevent the rebounding, induce it. How about the inhibition of hepatic genolysis? That's von Gierke disease. We're impairing the glucose release. Hey there, Crescent. Good morning. I think today I have to lock in and do a solo today, but whenever I play Toontown, I'd love to do a collab. Well, at some point we should join a just chatting at some point, but for the next couple hours, I'm locked in. But good to see ya. How about decreased muscle glucose utilization? So that's true in chronic diabetes, but it's not the cause of acute hyperglycemia. Okay, so the confusion, the sweating, the palpitations, that's hypoglycemia. Low to high is the rebound pattern, and this happens because the epinephrine causes the increased glucogenolysis. Cortisol causes gluconeogenesis and insulin resistance, and then glucagon increases the hepatic glucose output. All right, so there's the pathophysiology. And here is the bottom line. Rebound hyperglycemia after hypo primarily is due to increased hepatic gluconeogenesis. Now, just based on what I've written here, I wonder, can you guys guess the correct answer to this next question? Burkitt lymphoma is a really good guess. Really good guess. There's one other that affects the jaw. I'm glad you said Burkitt lymphoma because that is perfect. There's one more. So we have a 45-year-old man with a history of diabetes. He's got chronic non-healing ulcer on his right foot, and he's had it for 2 years. And the ulcer is located on the plantar surface. The foot is swollen and warm to the touch, but there's no systemic fever. X-ray reveals peripheral bone erosion, suggesting osteomyelitis. Which of the following organisms is responsible? Okay, so the osteomyelitis and diabetes, that's an interesting complication there. There's the filamentous gram-positive. If we say this is a gram-positive rod, and it has aerobic growth, and also there's no jaw in this one, so it's not actinomyces, even though that's what I wanted you guys to think about. Mass on jaw, right? Usually it progresses to osteomyelitis of the jaw. And so actinitis israeli should be one thing that comes to mind, along with Burkitt lymphoma, and things that are associated with the jaw. And actinomyces israeli particularly is where you can get osteomyelitis of the jaw. Typically they have poor dentition and multiple cavities. And just to give you a hint on this particular question, the answer to this question is going to resemble actinomyces israeli a little bit. So nocardia is a little bit more commonly on the skin and soft tissue infections if the patient is immunocompromised. And so the answer to this question is actually nocardia. So it's the chronic foot ulcering, the biopsy of filamentous gram-positive rods, and the lack of growth in anaerobic conditions makes this unlikely. Nice, very good. You got it right. Israeli, anaerobic, filamentous, and also that's more predominantly going to be on the jaw. And this is in anaerobic conditions, not aerobic. So a couple of reasons why actinomyces is wrong. Mycobacterium tuberculosis involves caseating granulomas and pulmonary symptoms, which we don't see here. Streptococcus pyogenes, acute cellulitis is associated with that, and also necrotizing fasciitis. Definitely not filamentous. E. coli is gram-negative, associated with UTIs. So both nocardia and actinomyces are filamentous gram-positive bacteria, but they differ in oxygen requirements. Anaerobic culture is not working, and that means it's not actinomyces, which is a strict anaerobe. Nocardia is aerobic. The pathophysiology is you have trauma and ulceration and diabetes, and so you have a breaching of the skin barrier. And then nocardia enters the tissues, and you have a slow progression due to the immune dysfunction, and you get osteomyelitis formation. So if this involved the jaw, and they had different oxygen requirements, I would have said actinomyces israeli for the answer. All right, for this question, we have a 4-year-old girl brought to the pediatrician by her parents due to concerns about slow developmental progress. She's got coarse facial features and a prominent forehead, distended abdomen. The girl has a history of frequent upper respiratory infections and joint stiffness, thickened calvi on X-ray, abnormal long bones, enlarged epiphyseal plates. She's got elevated lysosomal enzyme activity in the leukocytes. So she has mucopolysaccharidosis, and this comes from a deficient lysosomal enzyme, some sort of a disease there, and it causes the accumulation of some undegraded substances with downstream tissue damage. And so we know that the organism that's affected is pretty easy on this one just because they tell us. She has elevated lysosomal activity, and so it's going to be the lysosomes that are damaged, right? The mitochondria, that would be associated with like energy failure, lactic acidosis, and these are typically going to be associated with like poor energy, neurologic signs, maternal inheritance. Endoplasmic reticulum, that's associated with protein folding and secretory pathway stuff. And then why that's wrong is there's an endoplasmic reticulum dysfunction, like protein misfolding or glycosylation defects. That'll cause different syndromes like congenital disorders of glycosylation, without the classic coarse facies and organomegaly pattern. Peroxisomes, those are very long chain fatty acid metabolism diseases. And so for that, you should think of like Zellweger syndrome that's present with hypotonia, seizures, liver dysfunction, and also some developmental arrest. But these bone deformities that we see and the coarse are going to be typical of mucopolysaccharidosis. The Golgi apparatus, that's the trafficking post-translational modification center. And those Golgi defects like the M6P tagging errors and eye cell disease can secondarily affect the lysosomal enzyme targeting, but the primary organelle responsible for the clinical substrate accumulation and degradation is going to be the lysosome. So that's our correct answer, lysosome. Okay, we talked about the mannose-6-phosphate defect for Golgi apparatus, but it's not lysosome. So these are lysosomal storage diseases. The coarse facial features from the glycosaminoglycan deposition that distorts the connective tissue. The clouding would be Hurler, not Hunter. Frequent respiratory infections. You have an airway narrowing from mucopolysaccharide accumulation. We have to know these deficiencies. The alpha L deficiency is Hurler's, and Hunter's it's just the iduronate sulfatase deficiency. Would be a glucocerebrosidase deficiency, crinkled paper, Niemann-Pick, sphingomyelinase deficiency, foam cells, cherry red macula. So we got to know all those. Know the enzyme that's deficient and the pathophysiology. All right, so the bottom line is lysosomal enzyme elevation indicates a lysosomal storage disorder, like Hurler's, in this child. All right, so here we have a 60-year-old man presented to the clinic with progressive breathlessness over the last 3 weeks. He has a history of hypertension, managed with amlodipine, and is a former smoker with a 40-pack-year history. And the patient is afebrile. His blood pressure is 135/80, heart rate is 78, and respiratory rate is 18. Lung auscultation reveals bilateral basal crackles. Jugular venous pressure is elevated. Mild peripheral pitting edema is present. A chest X-ray shows bilateral pleural effusions and significant cardiomegaly. Echocardiography reveals a normal left ventricular ejection fraction. Lab tests show a low serum albumin level. Which of the following is the most likely mechanism behind this patient's condition? All right, so let's break this one down. So here we can have some chronic increased systemic vascular resistance. That's
pressure. Take the medication.
Okay, Siri was somehow activated there. That was not what I intended. So you have chronic increased systemic vascular resistance. That's hypertension. To work against higher, and so the body's going to adapt. And so you have adaptive concentric hypertrophy. The sarcomeres are going to develop in parallel. And that causes wall thickening and increased stiffness. And you have that low albumin that can cause the transudative effusions as well, but that would not explain the cardiomegaly and the elevated filling pressures as cleanly. So the reduced plasma oncotic pressure, that would be hypoalbuminemia, and that would be the transudative edema. But here, low albumin can actually cause peripheral edema and pleural effusions, but that would not explain the cardiomegaly and the elevated JVP, and also the pulmonary edema from the elevated left-sided filling pressures that are seen, and so that's actually not the right answer. The correct answer is going to be E, the elevated vascular resistance. All right, so here's the next question. We have a 22-year-old woman comes to the emergency department with complaints of fatigue and also muscle weakness. She has lost 10 pounds over the past month despite maintaining the same diet. She missed using a weight loss product, and she is 5'7", weighs 114 pounds, BMI of 18. Physical exam shows dry, brittle hair, lanugo. So what has she been abusing? Okay, so looking at her labs, she has hypokalemia and she has metabolic alkalosis. So you have to think what causes low potassium and metabolic alkalosis. It's going to be a diuretic. A diuretic would cause both of those symptoms. So she has the unexplained weight loss and also the hypokalemia and metabolic alkalosis. Insulin causes hypoglycemia and hypokalemia, but does not cause metabolic alkalosis. You would see the hypokalemia though. Corticosteroids can cause Cushingoid features. That would be with hyperglycemia and truncal obesity. Beta blockers can cause bradycardia and fatigue. Growth hormone causes acromegaly. So diuretics increase the sodium reabsorption. Volume contraction causes RAS activation, and aldosterone drives more hydronium and potassium secretion. You get chloride loss or chloride depletion and metabolic alkalosis. So she's taking the water pills, making the kidney dump the sodium, potassium, and chloride in water. And so you get rapid weight loss from fluid, but not the fat. You got to watch out for that potassium loss and metabolic alkalosis. Really dangerous. So bottom line is low potassium and muscle weakness suggests diuretic misuse, commonly seen in weight loss product abuse. Okay, a 36-year-old woman has a 5-year history of HIV. She has used combination antiretroviral therapy regimen that includes efavirenz. Her most recent viral load was undetectable. Her CD4 count is stable. Genotypic resistance testing reveals a mutation that decreases susceptibility to efavirenz. Which of the following proteins is most likely affected by this mutation? The answer is reverse transcriptase. You have to note that efavirenz is one of the NNRTIs. These other guys, the GAG precursors used for virion assembly. And to know this, To answer this question right, you have to know the HIV life cycle, how reverse transcriptase allows the virus to integrate to the host DNA. The mechanism is an NNRTI, mechanism of drug resistance. Yep, HIV works through reverse transcriptase. And oftentimes in monotherapy, you can get some resistance to mutations in the reverse transcriptase gene. Here's the bottom line. Efavirenz resistance mutation affects the reverse transcriptase, which is crucial for HIV replication. All right, so this is just a Hardy-Weinberg question, so pretty simple. We have an autosomal recessive disorder like cystic fibrosis in 1 of every 2,500. And so we take the square root so that we can get Q, and then we use the Hardy-Weinberg equation, which is P squared plus 2PQ plus Q squared is equal to 1. And we know the Q now is going to be the square root of both sides, so it's going to be 1 over 50. Now P is very small, or rather Q is very small, and so P is very large, approximately 1. And so you just multiply by 2, and you get 1 out of 25. And so the carrier frequency is 2PQ in this Hardy-Weinberg equation right here, because that would be the incidence of the autosomal dominant, and this is of the 2 little q's, autosomal recessive, full-blown cystic fibrosis. And so 2PQ is that carrier frequency. So it's 1 over 25. Very simple. So the heterozygous carrier frequency is approximately 1 out of 25. All right, here we have a 23-year-old man presenting to the clinic with complaints of muscle weakness and a cramping during exercise. He mentions that he feels fatigued shortly after starting any strenuous activity, and sometimes he notices dark urine afterward. His medical history is otherwise unremarkable. Physical examination is normal at rest. Blood tests taken after a short exercise session show elevated creatinine kinase with no significant rise in blood lactate levels. A muscle biopsy is performed, revealing an accumulation of glycogen with periodic acid shift positivity. These symptoms are associated with a deficiency in which enzyme? Well, he has muscle weakness and cramping, feeling fatigued, dark urine. That's all pointing us toward McArdle disease, which is a type 5 glycogen storage disease. So this seems like he has exercise-induced muscle cramps. And there's no rise in lactate, so there's a failure of anaerobic glycolysis due to the blocked glycogenolysis. And so it seems like the correct answer is going to be glycogen phosphorylase because it's McArdle's disease, glycogen storage type 5. And this is caused by deficiency of the muscle glycogen phosphorylase. And that's essential for breaking down the glycogen in the skeletal muscle during anaerobic activity. And if you don't have this, then the muscles can't access the stored glucose during exercise. And that leads to early fatigue, muscle cramps, rhabdomyolysis, which is why he has the dark urine. And also there's no rise in the blood lactate levels post-exercise. Now, acid maltase, that's going to be Pompe disease. Hey. Exercise intolerance and elevated creatine kinase. All right, this is the buzziest question ever. 15-year-old male, concerns about his testicle, one feels heavier, and he's uncomfortable after standing for long periods, and he's got the bag of worms texture. This is a varicocele. It's the dilated pampiniform plexus. Left side is most often affected, and the reason is that left-sided gonadal vein drainage to the left renal vein. So the answer is a varicocele. Painless bag of worms, enlarging. Hydrocele transilluminates with light. They're fluid-filled, not vein-related. Inguinal is a reducible mass, where the bulge increases with coughing. Torsion, acute pain, high riding. Epididymal cyst would be a smooth, well-circumscribed mass. So that bag of worms is due to the dilated veins. The increased temperature impairs spermatogenesis. Here are the key features. So the bottom line is varicocele presents with a bag of worms texture with heaviness in the scrotum, especially on the left side, because of the left renal vein situation we got going on there. All right, for this question, I'm just going to explain. Basically, a minor change in the radius can cause an extreme change in the flow, and it's to the 4th power. You should have to be aware of that when answering questions. So resistance increases exponentially as the radius drops, increasing the pressure needed to maintain the flow. And so kidney microcirculation is sensitive to the radius changes. So if it starts at 4 milliliters per second, and you cut it by half, it's going to go down to 0.25. All right, so it's a factor of 16 there. So if you shrink a blood vessel's radius by half, then the blood flow gets cut by 16, a factor of 16. That's Pacelli's law, because the flow is proportional to the 4th power of the radius. All right, here we go. A 30-year-old man presents to the emergency department with repeated episodes of sudden palpitations, sweating, and overwhelming sense of doom. The episodes last 10 to 15 minutes and occur approximately 2 to 3 times a week. He's been experiencing this for the past several months, and these episodes occur without warning and are not associated with any specific triggers. Between episodes, he feels relatively normal, but is constantly worried about the next attack. All right, so this is the sudden doom stuff. That's like panic disorder. It's the fear, the autonomic hyperarousal, the sense of impending doom. So he's got a panic disorder. Feels like you're about to die, so your body is telling you, and you have palpitations, sweating, sense of doom. It usually lasts for about 10 minutes, happens 2 to 3 times a week, isn't triggered by anything else. And between, you always worry about the next one. For treatment, you give them an SSRI or CBT, and the attacks last minutes, not hours typically. It's just a surge of norepinephrine from the locus coeruleus that leads to autonomic hyperactivity, and you misinterpret those body senses, and your body's like, oh my gosh, I'm going to die. And you have a fear of future attacks, and that causes more of a panic disorder. So acutely, you can actually give them benzodiazepines Long term, you give them SSRIs and CBTs. And you have to also rule out any medical causes as well. So the answer is C, panic disorder. Trap answers by the wrong. Thyroid toxicosis. That can cause palpitations and sweating, but it would show up with systemic signs like weight loss, tremor, heat intolerance, also like abnormal TSH and T4 levels, and the labs here were normal. Social anxiety disorder, that attack would occur only in social situations with a fear of embarrassment. But here they're just random. Generalized anxiety disorder. So anxiety is chronic and pervasive here. There's worrying most days for greater than 6 months, not episodic. And then cardiac arrhythmia, that would cause palpitations, but not like a sense of doom, and sweating and episodic anxiety. So the bottom line is panic disorder is characterized by the recurrent, unexpected panic attacks and persistent worry about future episodes. All right, so here, our next question, we have a 7-year-old boy brought to the pediatrician for a routine checkup. His vaccination record shows he's due for updates on several vaccines. And so they give him inactivated influenza intramuscularly. Which of the following immune responses is directly responsible for the protectiveness there? Well, it's not going to be CD8, right? Because intramuscular influenza vaccines, they do not replicate inside of the cells. And so they can't stimulate MHC class 1. Instead, they have to activate the MHC class 2. And that would activate the CD4 positive T helper cells, which then stimulate the B cells to produce the neutralizing antibodies. Because they're processed extracellularly and presented on MHC class 2 molecules. And then the B cells come in and do their thing. Okay, so that's the reason why CD4 helper T cells that facilitated cytotoxic response, while CD4 T cells help the B cells, not kill the infected cells directly. CD8 would be only activated by live attenuated or intracellular pathogens on MHC1, and that's not the right answer. Induction of the cytotoxic memory T cells. So again, the cytotoxic T cell responders require intracellular antigen processing, and that is not going to be triggered by inactivated vaccines. How about mucosal? Robust mucosal response. Well, IgA is important for intranasal vaccinations like live attenuated flu mist, but intramuscular vaccinations primarily triggered the systemic IgG, not IgA. And so production of neutralizing antibodies is correct. Shots fired. Okay, there's the mechanism that we just kind of discussed, and we also discussed a lot of these things as well. Inactivated vaccines cannot replicate in the host. Their phagocytosis are presented on MHC2, stimulating CD4 positive T cells, which then help the B cells make antibodies. Okay, here's some inactivated vaccines like polio, hepatitis A, rabies, and the intramuscular flu. Live vaccines like MMR, varicella, intranasal flu, and B cell deficiencies are poor response to inactivated vaccines. IgG is systemic protection, long life, and best for long-term defense. And CD8 positive activation with inactivated vaccines cannot enter the cytoplasm when processed on MHC1. Mine inactivated vaccines primarily provide long-term protection through the production of neutralizing antibodies by B cells. All right, so there's our hippocampus. Give us a little bit of a better look here. You can see the hippocampus right here, and then blue, and the blue as well. There's our hippocampus right there. There's the thalamus. I can see the amygdala. There's the cingulate gyrus, the hippocampus, the seahorse of the brain. Corpus callosum right there. There's the cingulate gyrus, our little baby pineal gland. Again, our hippocampus. Starting to see that trend. Here's the mammillary body. There's the hypothalamus right there. The fornix, the corpus callosum, pineal gland, cingulate gyrus. There's your hippocampus right there. There's the amygdala. There's the basal ganglia. Here's what happens when you see a spider. It goes up to the visual thalamus, into the visual cortex, into the amygdala. All right, so that's so fun. The brain is so fascinating. Early this morning, I just sat up in my bed thinking. Much the same way we're not capable of shutting off our own breath, we can't stop thinking. We can't stop experiencing the world through our lens, whatever our means. And yet it seems like there's a way that you can detach the entity of self from that ongoing onslaught of cognition. And it's a strange meditative experience to sort of like a ghost sink through the command chair in your own brain and allow the autonomous machine to continue without you. That was a surreal experience that I had this morning as I was meditating. Sid agrees. The brain is awesome. Blows my mind. All right, 60-year-old man, history of chronic obstructive pulmonary disease and coronary artery disease, is undergoing a cardiac bypass surgery. He experiences unexpected drop in blood pressure due to anesthesia complications, resulting in prolonged hypotension that resolves after 10 minutes. 2 weeks later, he presents with memory difficulties and inability to recall things. MRI of the brain reveals damage consistent with hypoxic injury. This is just asking us about hypoxia in the brain. It's a very simple question. This is about the hippocampus, which is the most sensitive region of the brain to hypoxic ischemic injury. And so that causes selective memory loss. That's anterograde amnesia, and that's after global hypoperfusion. And that's kind of all there is to it. There are a lot of other answer choices, and we have to know a little bit about each one. So the caudate nucleus, for instance, here you would see the basal ganglia lesions that cause the movement disorders, not isolated memory stuff. So it's not that. The thalamus, The thalamic infarct can cause sensory and consciousness changes, but memory loss is not going to be seen there. And the occipital and the brainstem would cause autonomic and vital function failure, not selective memory impairment. So there you have it, folks. Particularly the CA1 pyramidal neurons are vulnerable to ischemia and hypoxia. Step 1 loves asking about all these areas of the body that are vulnerable to hypoxia. So the bottom line, memory impairment after prolonged hypotension suggests hippocampal damage due to hypoxic injury. All right, in our next question, we have a 55-year-old man presented to the emergency department with complaints of severe non-bloody diarrhea and abdominal cramping for the past 4 weeks. He reports significant fatigue and has noticed his skin feeling dry despite drinking ample fluids. He has lost approximately 13 pounds. Physical examination reveals dry mucous membranes and decreased skin turgor. Blood pressure is 90/60. Temperature is 98.1. Lab studies reveal hypokalemia and metabolic acidosis. Stool studies are negative for blood and white blood cells and infectious agents. A CT scan of the abdomen identifies a 3-centimeter mass in the small intestine. Administration of octreotide has been shown to alleviate his symptoms. Which of the following substances is this tumor likely secreting? Sedal, you are literally just too good. Guys, Sedal is like so freaking cracked. It blows my mind, man. Sedal should be teaching the class. I swear. I am so impressed. And by the way, this is actually my favorite syndrome. Well, maybe that's a bad thing to say, but I love the WADA mnemonic. I love that. Sorry, I was helping a client. He's wondering how to access the Twitch. But yes, okay, so non-bloody chronic watery diarrhea, hypokalemia, and metabolic acidosis. There's octreotide that relieves the symptoms, neuroendocrine tumor. This is the vasoactive intestinal polypeptide. Yeah, dude, I'm so impressed, Sedal. You're just super cool. All right, so glucagonimas would be caused by necrolytic migratory erythema and diabetes and anemia, not water stuff. That's not watery diarrhea, not glucagon. But you would see that necrolytic migratory erythema and diabetes. Insulin, that's insulinomas, recurrent hypoglycemia with relief on eating. You eat and you're fine, right? So no, not an insulinoma. Somatostatin, that would be like a somatostatinoma, and that's seen in like diabetes, diarrhea, gallstones, hypochlorhydria, but not severe watery diarrhea. And then vasoactive, yep, that's the correct answer. Watery diarrhea, electrolyte wasting, right? Gastronomas, those would be ulcers, diarrhea due to acid hypersecretion. Insulinomas, Whipple's triad. Glucagonomas would have necrolytic migratory erythema, and somatostatinoma would have diabetes and gallstones and CF. So the watery diarrhea, the hypokalemia, achlorhydria, that's a vipoma. Octreotide is a somatostatin analog, and electrolyte loss is going to be seen here in metabolic acidosis, and so you have massive secretory diarrhea. Burhan, yes, this is really live. Yes, it is. Hello, Burhan. How can I prove that it's live to you? Ready? Watch this. Live. Burhan. There we go. Although I am curious, what would it be if it weren't live? Like, is there a way to do this not live? Asking for a friend. But yeah, vipoma, chronic watery diarrhea, hypometabolic acidosis, WADA syndrome, right? WADA. By the way, Burhan, if you want to join the Twitch, you can interact with the chat. Oh, thanks, Burhan. That's super nice of you. Live in a good mood. I felt a little bit not as like chipper this morning, so I'm really happy to hear that. Yep. All right. So WADA, what does the WADA syndrome mean, right? So the WADA syndrome, and it's not like water, right? It's WADA. You have to say it cool like that. WADA, right? WADA stands for watery diarrhea, hypokalemia, and achlorhydria. That's what's going on there. All right. So achlorhydria is when the stomach does not produce hydrochloric acid. And let's do the bottom line. Small intestine mass likely secretes vasoactive intestinal polypeptide, causing severe diarrhea and metabolic acidosis. All right. This next one is easy points. Easy points. What do you think of when you have a blunt, penetrating abdominal blow? You're playing football or something, and you have a blunt or maybe even a penetrating abdominal trauma. What should you think of? Here we go, folks. I'll let you guys see the question. You nailed it, Sedal. Nicely done. All right. So yes, 28-year-old man admitted to the hospital after a car accident. He was a restrained driver and hit a tree while traveling at high speed. And he's going to shift a mediastinum to the right. And you have fluid collection in the left upper quadrant. And so which of the following organs is most likely injured? Okay. So the answer is going to be the spleen, as Sedal said. Very, very nice. So you have that left-sided rib fracture and left upper quadrant pain and hypotension. You should think of a splenic rupture on the left side. You have the hemothorax opacification and mediastinal shift. That means there's a massive hemothorax from the intra-abdominal bleeding that crosses over. So it's the spleen. Why is it not the diaphragm? Diaphragmatic rupture. You'd see the abdominal contents in the thorax. That's wrong because there's no bowel sounds. It's due to blood, not organ herniation. So basically, if it were something with the diaphragm, then an injury would cause bowel sounds in the chest and it'd have an elevated hemidiaphragm and also herniation and not large volume hemithorax. The left kidney, that's a retroperitoneal hemorrhage. And so that would cause flank pain like hematuria, not intrathoracic blood with a medistat shift. So the bottom line, left rib trauma with hemithorax suggests splenic injury with a high impact abdominal accident. Okay, this is actually a really good question right here. So a researcher is interested in assessing the relationship between daily screen time and the prevalence of dry eye in a corporate office building. And so what he does is he surveys on a single day the average hours spent and also the dry eye-ness at the same exact time. So what's the answer if it's the same exact time? Kind of give it away with the way that I phrased the question. I apologize for that. But what do you think? Sidel says cross-sectional. You were 100% right. Cross-sectional. That's exposure and outcome at a single point in time. 100% right. Nailed it. Yep, really good. So the data is collected once on a single day. The exposure and the outcome are measured simultaneously. Incidence goes into the bathtub of prevalence, and then mortality drains it out. All right. There's a 45-year-old man presented to the clinic with a history of recurrent fevers, flank pain, and episodes of hematuria over the past 10 years. He has been treated multiple times for urinary tract infections. On physical examination, blood pressure is 150/95. Wow, that's high. Ultrasound of the kidney shows bilateral renal scarring and also calyceal dilation, which of the following is most likely the underlying cause of this renal condition. So we have some recurrent UTIs and also some scarring, and there's nephropathy. And there's the calyceal blunting and the hypertension and elevated creatinine. So what's happening here in this question is we have a 45-year-old man. He's got some flank pain, episodes of hematuria. He's been treated multiple times for urinary tract infections, and his blood pressure is 150/95. And we have some scarring and a lot of problems there. And so what's happened is he's got some vesicular reflex going on. He's got some nephropathy. It's a form of chronic tubulointerstitial nephritis that's caused by long-standing VUR. Fibromuscular dysplasia would be the string of beads. Polycystic kidney would be multiple bilateral renal cysts, and diabetic nephropathy would be the Kimmelstein-Wilson nodules. So the bottom line is vesicular reflex is most likely associated with UTIs and renal scarring in this patient. And by the way, these vesicular reflexes, these are congenital, and so they can be congenital or they can be acquired, and they're defects in the uterovesicular junction and allows the backflow of urine from the bladder into the ureters and the kidneys. And so over time, that causes a chronic pyelonephritis, and that leads to interstitial inflammation, renal fibrosis, and also scarring. And it's particularly going to happen in the upper and the lower poles of the kidney. It also presents with recurrent UTIs and flank pain and hematuria, and also some hypertension in adults. A 5-year-old girl is brought to the clinic by her mother due to difficulty walking and frequent falls over the last month. She also has difficulty with tasks and fine motor skills like buttoning her clothes, and there's a vitamin deficiency. All these neural things are going to make you think of vitamin E, except this is not ADHD actually. This is macrocytic anemia. And so there's actually ataxia. So there's actually going to be a B12. If it were ADEC, then maybe the neurological symptoms would make you think of vitamin E, but this is B12, looks like, because of macrocytic anemia. That's why you always read the full question. Typically, a vitamin E would be like they have cystic fibrosis, pancreatic insufficiency, and then they have some sort of like muscle weakness, and maybe they even have some spinocerebral tract demyelination. But if you read macrocytic anemia, and that's the cause, then vitamin E is probably off the table, and instead it's going to be vitamin B12. So it's the posterior column signs. Different sign. Okay, so vitamin B12 deficiency, it results from malabsorption in the terminal ileum resection. And so you have like associated with Crohn's disease, pernicious anemia, pancreatic insufficiency, and that leads to megaloblastic anemia and neurologic findings like subacute combined degeneration. And the neurologic findings are due to impaired myelin synthesis from methylmalonyl-CoA buildup. And so you have wide-based gait and also falls and difficulty walking, which leads to ataxia. And there's also loss of vibration, proprioception because of the dorsal column damage or dysfunction. There's also absent reflexes, which indicates peripheral neuropathy. There's macrocytic anemia, megaloblastic due to B12 or folate deficiency. And there's a history of bowel resection. That's going to be a loss of your terminal ileum and a B12 malabsorption. So here's the bottom line. B12 deficiency causes ataxia and macrocytic anemia, especially in patients with a history of bowel resection. All right, so in this question, we have a 33-year-old woman presents to the emergency department with heavy menstrual bleeding 3 days after a menstrual period starts. She has no significant past medical history, and she has no medication, takes no medication. Physical exam shows mild pallor and a pelvic exam with enlarged boggy uterus. Lab studies show hemoglobin of 9.5. Normally, it's 12 to 16. An ultrasound of the pelvis reveals uniformly enlarged uterus. The gynecologist starts treatment to decrease the bleeding by enhancing uterine contractions. The medication administered acts through which of these following mechanisms? Okay, so first I want to talk about why is it boggy, right? Got this uterus, enlarged boggy uterus. So it's soft and spongy on palpation. That's what it means by boggy. And there's the infiltrating endometrial tissue bleeds that occur cyclically in the muscle wall, and that causes edema and also that boggy texture, right? So that's the reason why it's boggy in the first place. Why is it uniformly enlarged? Well, unlike fibroids, which cause asymmetric and firm, irregular, enlargement. The adenomyosis, that spreads diffusely through the entire myometrium. That causes symmetrical hypertrophy of the uterine wall, and that's why the uterus becomes globally enlarged, not nodular or lumpy. Right? So it's different than fibroids. Fibroids are irregular, asymmetric enlargement, and they have firm consistency, and they're discrete masses. And the symptoms are similar, but the pain is less cyclical, and the age differences, so they're still going to be like 20 to 40, but maybe adenomyosis can be like 35 to 50. All right, so what causes the enlargement is the repeated cyclical bleeding inside of the uterine wall, and that causes inflammation, hypertrophy, smooth muscle, hyperplasia, and over time you get thickening and the enlargement of the uterus. So the boggy adenomyosis, uniformly enlarged, not fibroids, right? So basically adenomyosis is diffusely invasive endometrial tissue, soft, uniformly enlarged uterus due to the chronic bleeding and also all the inflammation. So that's why it's boggy. That's why, it's uniform. Okay, so we talked about this, the boggy uterus stuff, why it's adenomyosis, we know that. Inhibition of calcium channels. So the smooth muscle relaxation would be associated with that, but this is wrong because that would reduce the uterine tone. We want the opposite. Blockade of potassium antiarrhythmics class 3 would do that. Stimulation of beta adrenergic receptors, that's smooth muscle relaxers. Wrong because beta 2 stimulation causes uterine relaxation. And inhibition of cyclooxygenase enzymes, that would be like NSAIDs, COX inhibitors, reduce prostaglandins and decrease uterine contractions. There's the bottom line. Heavy menstrual bleeding is treated with oxytocin, which activates the G protein coupled receptors to enhance contractions. All right, so here we have a study of incidence. That's the new cases. And at the start, 80 out of 1,200 were diagnosed, and over the next one, 60 additional ones. So what percentage is it going to be? Well, what we do is we go 60 divided by the 80 there, minus the whole 1,200, and then we just divide, and we get around 5.5. So incidence is just going to be the new people who get the disease, so you have to not measure all the old ones. Incidence is the new cases as a fraction of the total population. So here's the bottom line. Annual incidence of influenza in this population is 6.5, calculated as 60 new cases over 1,200. Okay, here's a medical fact. Every individual has a unique tongue print, just like your fingerprints. That's an interesting medical fact. Also, the fastest growing nail is on the middle finger. Yeah, that's right. If you think about breathing, you'll have difficulty breathing. That is very true. Also, when you sneeze, it's greater than 100 miles per hour, whereas coughs are just 60 miles an hour. All right, hopefully that was a fun medical fact. On to our next one. A 35-year-old male construction worker falls from scaffolding and lands on his back. He is brought to the emergency department for evaluation. On arrival, he is alert but complaining of severe lower back and abdominal pain. Good to see you. So he's complaining of severe lower back and abdominal pain. His vital signs show blood pressure of 100/60. Heart rate is 120 beats per minute. Respiratory is 22 breaths per minute. Physical examination has ecchymosis of the lower back and flanks and diffuse abdominal tenderness, and the FAST reveals presence of free fluid in the abdominal cavity during exploratory laparotomy. Initial inspection of the abdominal viscera shows no overt injuries, but upon palpation beneath the liver, a sudden gush of blood occurs. The patient's blood pressure drops precipitously despite resuscitative efforts. Which of the following is most likely the source of the hemorrhage? Okay, so this is a pretty crazy accident here, right? Landing on your back, and then blood pressure is like low, you're losing blood, and you've got all this ecchymosis, so tons of hemorrhaging. And so what is this? This is like the most lethal intra-abdominal vascular injury that you can possibly get from blunt trauma. The most lethal, what is it? Okay, so there's a collapse. And so this is going to be avulsion of the hepatic veins from the inferior vena cava. Avulsion from the inferior vena cava. All right? So there's the sudden gush of blood on palpating along the massive intra-abdominal hemorrhage. That suggests there's injury to the retrohepatic vena cava, and these veins are really thin-walled. The vena cava and the hepatic veins, and they have high-volume conduits that connect the liver to the IVC. And there's trauma-induced avulsion. In this case, it's rapid, catastrophic bleeding. It's difficult to control surgically. All right, so it's avulsion, which is like the ripping out, right? It's just like disconnecting those veins from the inferior vena cava. So bad. Very, very, very bad. Okay, let's look at these other ones. Rupture of the renal artery would cause retroperitoneal, not intraperitoneal bleeding. Avulsion of the inferior vena cava from the right atrium, that would be rapidly fatal, but it's not associated with liver manipulation, and so that wouldn't present as a free intraperitoneal blood alone. So that's the reason why that's wrong. Avulsion of the superior mesenteric artery from the aorta. So that one causes bowel ischemia, not sudden hemorrhaging through liver manipulation. And then the rupture of the spleen, that would cause left quadrant hemorrhaging. It'd be visible on the initial inspection and not triggered with palpating beneath the liver. Alrighty, so blunt abdominal trauma with initial hemodynamic compensation followed by rapid decompensation during exploration. Retrohepatic venous injury, specifically the hepatic vein avulsion from the IVC. It's impossible to control surgically, most lethal vascular injury you can possibly get. Here's the bottom line. Avulsion of the hepatic veins from the inferior vena cava is likely the source of hemorrhage and blunt abdominal trauma. And I see a question in the chat from Zishan. One day before the exam, you're taking it tomorrow? Good luck to you, my good friend. Yeah, I would say take it easy. Relax, rest, have a good day. Just chill for a second. Don't do tons of practice questions. Rise just like you would at the time you would for the exam. Get a good night's sleep. That's the biggest thing you could do. Best of luck to you, my friend. Best of luck. Yep, everybody wishes you good luck, Zishan. You're going to nail it. Alrighty, so here we go. The photos will catch up soon. We have a 28-year-old woman visiting the clinic. She's in her second trimester of pregnancy. She mentioned she's been feeling well with no significant fatigue. Her pregnancy has been uncomplicated and her pulse is at 78 beats per minute. Her blood pressure is at 110/70. There's no enlargement or tenderness. Lab work shows this. The increased, which of the following is responsible for the observed findings? All right, so thyroid pregnancy stuff. Let's talk about it. So the total thyroid hormone level is going to go up, but the free levels stay normal. And that's all because of estrogen. Estrogen boosts the thyroxine binding globulin production in the liver. And that binds more T4 and that raises the total levels, but the body compensates to keep the free T4 and the TSH in check. So if you see a pregnant woman, she has high total T4, but normal free T4 and also TSH, it's literally just estrogen. No big deal. Just the estrogen is all that it is. I don't know what accent that was, but so the answer is estrogen. All right, so during pregnancy, estrogen stimulates the liver to produce more thyroxine binding globulin. Yes, that's what Sadal said. Good. Yes. Nice. This leads to increased T4 since more is bound, but free remains normal because you're just binding more of it because of estrogen. Insulin doesn't affect thyroid binding globulin, ionizing hormone suppressed during pregnancy. Human chorionic gonadotropin, it's a TSH mimic, can cause transient low TSH, but they have normal, and so they don't have human chorionic gonadotropin mimicking. DHEAS would be the adrenal androgen, and that is involved in fetal adrenal development, not the thyroid stuff. Not the thyroid stuff. So basically, estrogen increases the thyroid binding globulin, which then increases the total T4. So estrogen rises significantly during pregnancy, especially from the placenta. And then estrogen stimulates the liver to increase synthesis of thyroxine binding globulin. And you have more thyroxine binding globulin, that means there's more binding sites for the thyroid hormone in the blood. And so as more T4 binds to thyroid binding globulin, the free T4 transiently drops, and the pituitary senses that drop in the T4, and it increases the TSH ever so slightly to restore that balance. And you get more T4s produced to saturate the extra thyroid binding globulin. And then you get a normal or restored free T4. And so you can have elevated T4, normal free T4, and then TSH is normal, but maybe dipping slightly early on from the HCG, and then it will normalize afterwards. So pregnancy, high estrogen, high thyroid binding globulin, high total T4, and then the free T4 is also going to stay normal. So always check the T4 and the TSH in pregnancy, not just the total T4, because you might mistakenly diagnose hyperthyroidism. Cool beans, guys? Are those beans cool? Increased estrogen during pregnancy elevates the total T4 levels with free T4 and TSH remaining normal. All right, here we go. A 58-year-old woman presents to the clinic with complaints of fatigue and night sweats over the past 2 months. She reports mild diffuse lymphadenopathy. She has a palpable cervical axillary lymph node, but no hepatosplenomegaly. And then we got the hemoglobin of 12.5, hematocrit of 37, leukocyte count is 20,000, segmented neutrophils 30, and we have a whole bunch of other labs to let you guys look at here. Flow cytometry, analysis of peripheral blood, lymphocyte reveals all of the following. And look at that. Wow. Oh, it disappeared. Which of the following findings on flow cytometry is most indicative of clonal lymphoid proliferation in this patient? All right, so we know there's monoclonal B expansion, and that's going to skew the kappa lambda light chain stuff. All right, so that ratio is going to be skewed. That's just one of the features of CLL that we have to know. And CLL is going to show co-expression of CD5 and 19 plus the 23 positivity. And so yes, it's the skewed ratio is what's involved here. And so they have CLL, so they have the surface globulin light chain restriction, and that shows strong kappa bias, 80-5. So it's a weird lopsided kind of thing there. It's normal. Normal is 2.2 to 1. Cervical lymph nodes are not palpated in the cervix. So high percentage of CD19s, that's a B cell marker. And so that's going to be normal or malignant. It does not necessarily indicate clonality. And then the CD5, T markers, not specific for it. CD23 helps distinguish it from mantle cell lymphoma. And absolute lymphocytic count is a whole host of them, so suggestive but non-specific. All right, so we got to diagnose CLL with flow cytometry. That's what this question's about. Fatigue, night sweats, lymphadenopathy, these are B cell symptoms. Lymphocytosis of 65 suggests there's some sort of leukemia going on. And that's the immunotype of CLL. And then we have these changes in the expansions of B cells with kappa light chain. So that's really the kicker right here is this kappa lambda ratio. You have a neoplastic transformation of the B cells, clonal expansion, loss of diversity, and that skews the kappa lambda ratio. You have malignant clonal infiltrates in nodes and blood and lymphadenopathy and lymphocytosis, immune dysregulation, and hypoagamoglobulinemia or autoimmunity. So here are the key features right there. And yeah, 80% of patients with early stage CLL are diagnosed incidentally just from routine blood work. So really just make sure to look out for this blood work when you're diagnosing patients. And here is the bottom line, my friends. The surface kappa to lambda light chain indicates clonal proliferation in suspected chronic lymphocytic leukemia. Very nice. Very good stuff. Here's the next question. We have a 68-year-old man brought to the clinic by his wife due to sudden onset dizziness, weakness, and blurred vision that started 3 hours ago. He has a history of smoking, peripheral artery disease, and hyperlipidemia. On arrival, he is pale and sweating profusely. His pulse is 115 per minute. His blood pressure is 88/55. Abdominal examination reveals an ill-defined pulsatile mass in the midline. Neurologic examination is unremarkable. An E scan of the abdomen is performed. Which of the following is the most likely diagnosis? All right, so let's look at these most important little figures here. I'm going to highlight a lot of the stuff so we can just highlight the most important thing. I kind of want to highlight happy there. Basically, the big thing that I would note here is there's sudden hypotension. There's a pulsatile mass in the midline. Okay, that alone tells you that we have a surgical emergency. This is also classic in older males, let's say, and they have some sort of a vascular disease history. So looking at these, I would think older male, vascular disease history, blood pressure is low and it's acute, and pulsatile mass. Sadal said it. Ruptured aneurysm aortic. Very, very nice, right? Blown out from within. So they have hypovolemic shock and abdominal pulsatile mass. So it's a AAA. Myocardial infarction associated with chest pain and ECG changes. Acute pancreatitis has epigastric pain radiating to the back and elevated lipase and amylase. Bowel obstruction, you have abdominal distension and high-pitched bowel sounds. And that's wrong because obstruction does not cause pulsatile masses. And then the kidney stones, flank pain, hematuria. So we need to understand abdominal aortic aneurysm, dilation of the aorta, usually below the renal arteries. Risk factors are male sex above 65, smoking, and atherosclerosis. Most of them are asymptomatic until they rupture, leading to retroperitoneal bleeding, hypotension, and death if untreated. Physical sign is pulsatile abdominal mass. So smoking is a huge risk factor, atherosclerosis and peripheral artery disease, male sex, and Marfan and Ehlers-Danlos syndrome. Here's the pathophysiology. You have atherosclerosis, which damages the aortic wall. You have the weakening of the media and the adventitia. You have progressive dilation, which forms the aneurysm. And then there's rupture that causes retroperitoneal hemorrhaging. There's compression of nearby structures, causing possible flank and back pain. All right, so 50% of patients with the ruptured AAA die before they even reach the hospital. And so look out for smoking, peripheral vascular disease, and hyperlipidemia. Here is the bottom line, my friends. Sudden dizziness, hypotension, pulsatile abdominal mass suggests a ruptured abdominal aortic aneurysm. Here we have a 45-year-old man presenting to the clinic with the complaints of right shoulder pain that has been gradually worsening over the past month. He reports no history of trauma, but mentions that he works as a bank teller and has recently taken up swimming as a leisure activity. He also discloses a 10-year history of rheumatoid arthritis, for which he takes long-term corticosteroid therapy. Physical examination shows tenderness and reduced range of motion. An X-ray of the shoulder reveals decreased bone density and proximal humeral fracture. Which of the following conditions is most likely responsible for the radiographic findings? Chest noob is thinking C, and Sadal is thinking osteoporosis. Okay, so he's got long-term corticosteroid use, and he's got a fracture without trauma. So he's taking corticosteroids long-term, and on the radiograph, he has decreased bone density. So Dr. Saswan is thinking D because of the steroids. Yes, it is osteoporosis because of the steroid use. All right, so they have atraumatic shoulder pain and the proximal humerus fracture. There's decreased bone density on imaging. Long-term corticosteroid use and rheumatoid arthritis are risk factors for secondary osteoporosis. And let's talk about the mechanism for this one. So glucocorticoid use inhibits the osteoblast differentiation and it promotes osteocyte apoptosis. All right? Chest noob says this is why I don't want to go into medicine. That's totally fair. Rheumatoid inflammation, cytokines, IL-6 and TNF-alpha stimulate the osteoclast. Decreased bone formation and increased reabsorption. There's a net loss of bone mass, and there's weakened trabeculae, which is fragility fractures, especially in axial and proximal limb bones. All right. Low bone mineral density on imaging. No trauma, yet fracture. The fracture locations are vertebrae, hip, wrist, proximal humerus, steroid use, and normal labs unless it's severe. usually normal, all of these things in osteoporosis. So 50% of women and 20% of men over age 50 have some sort of an osteoporotic fracture in their lifetime. All right, so chronic shoulder pain, no trauma, proximal humeral fracture. He's got the corticosteroids. So those are all risk factors there. Prolonged corticosteroid increases the fracture risk, making osteoporosis the likely cause. That's the goal, making everybody MDs. A 67-year-old woman presents to the clinic for follow-up after undergoing a biopsy that is confirmed with diagnosis of metastatic lung cancer. When the physician discusses the diagnosis and prognosis with her, she becomes tearful. So she's got an emotional response. She's in distress. And she says, how am I supposed to handle this? So first of all, you identify and you say, how am I supposed to handle this? That's the direct empathy, right? She wants empathy. And so we have to do communication. We have to help her out. And then so we have to always empathize. And remember, the way to do these ethics questions is you always have to think, what is the principle that you're going to be doing? Okay, so empathy, you have to say, okay, this must be difficult for you to hear, right? You have to provide some sort of an empathy response if they are in distress. There's your ethics question for you. There are many resources available. Here, our goal is to empathize and empathize. None of these empathize, okay? So we definitely have to empathy and validation. That's one of the principles that you have to be aware of for ethics. Okay, so validating the patient's feelings is crucial in addressing emotional distress after cancer diagnosis. Here you go. All right. Here we have a 16-year-old girl presents to primary care physician with a 7-day history of fatigue, fever, and sore throat. She's got a positive monospot test and atypical lymphocytes and irregular nuclei. The atypical lymphocytes are which of the following? What are they? She's also got a temperature. So we know that she has infectious mononucleosis, right? She's got Epstein-Barr virus. Monospot test tells us that. And we know this infects the CD21. And then we know the atypical lymphocytes are going to be E. Yes, Dr. Sawasan. Nice. You guys are both correct. Very, very good. It is going to be the T lymphocytes. And you're correct. It is the CD8 T cell lymphocytes. That's correct. All right. Killer T's in monomadness. Epstein-Barr virus infects the B cells, but the atypical lymphocytes are reactive CD-positive T cells. Splenomegaly occurs from T cell proliferation. So Epstein-Barr virus infects the B cells via the CD21 receptor, and the immune system responds with your CD8 positive cytotoxic T cells, which appear as large atypical lymphocytes on the smear. EBV infects the B cells, but the atypical lymphocytes are not themselves. They are the reactive T cells. And that's kind of the hardest part about this question, if we're being honest. Good morning, Renata. Good morning. Renata's been grinding like crazy. We're here to cheer her on. You got this. So, Epstein-Barr virus is going to infect the B cells through CD21, and then we have the CD8 positive T cell response. That's how it goes. If I were to say ciprofloxacin, what would you guys think of? Ciprofloxacin. That's awesome, Sadal. Here we go. A 62-year-old woman presents to the clinic with a 3-day history of increased urinary urgency, painful urination, and left-sided flank discomfort. She reports a low-grade fever and chills over the past 24 hours. Her past medical history includes recurrent urinary tract infections. Vitals, you have a temperature of 100.9, heart rate is 92, and the respiratory rate is 92 per minute. Nice. Tendinitis and P450 inhibitor, fluoroquinolones, very good. I was especially thinking of fluoroquinolones for this one, and we'll see why in a second. But all amazing answers. This is good. Urine analysis, we have positive leukocyte esterase is 2+, and previous urine culture is growing Klebsiella pneumonia resistant to several antibiotics, including ciprofloxacin. Genetic analysis indicates the resistance is likely due to a mutation. Which of the following is the mechanism of resistance? What do you guys think? What are you guys thinking? So there's a resistance to several antibiotics, including ciprofloxacin. That means there's fluoroquinolone, as Imran here said. And Dr. Sawasan says, A, yes, alteration of the target site of the DNA gyrase. Good, Sadal's got it correct as well. Nice. This is fluoroquinolone resistance. Now, Klebsiella pneumonia also is important. And that's a gram-negative rod that's known for the horizontal gene transfer. And then genetic mutations, right? That points away from enzyme acquisition like beta-lactamase stuff. Fluoroquinolones, topoisomerase 2, that would be the DNA gyrase. And positive nitrates and all that stuff confirms upper UTI. Okay, resistance is futile to fluoroquinolones. Fluoroquinolone resistance is commonly due to mutations of DNA gyrase. DNA gyrase is the bacterial target of ciprofloxacin. A mutation changes the binding site so the drug can't inhibit DNA replication. All right. And we're also thinking C, so let's talk about that one. Poor mutations can contribute to the resistance, but typically not enough alone, especially affects the beta-lactams. All right. So mutations in the beta-lactamase enzymes, that would be carbapamase, and that's for penicillins and cephalosporins. Modification of 23S RNA in the 50S, that is linezolid and macrolide resistance. That targets protein synthesis, so it's a little different. All right, so fluoroquinolones inhibit the DNA gyrase, and Klebsiella is an encapsulated gram-negative rod, common in UTIs and nosocomial infections, and fluoroquinolone resistance mechanism is DNA gyrase. The GYRA mutation is the target site, and you have positive nitrates and 2+ leukocyte, as well tells you that you have a UTI. So untreated polynephritis, sepsis, and renal scarring. So fluoroquinolone resistance is so common that over 25% of Klebsiella isolates can be resistant in hospitals. So crazy. What a weird world we live in, right? We're just a bunch of like evolved apes running around infecting each other with nosocomial infections that gain resistance in hospitals. And here we are studying on a YouTube stream. What's going on? It's just what a time to be alive. Here's the bottom line. Let's just dive in. Klebsiella pneumonia resistance to ciprofloxacin is primarily due to an alteration of the target site of DNA gyrase, which you guys all know because you're a bunch of champs. Alrighty, guys, we only have 11 more questions until we finished all of MBME 30. Wow, we've done this for 20 hours or so. Okay, so here we go. Oh, wow, you already answered the question. E. Okay, not quite. Do you have another guess instead of E? So here we go. 55-year-old woman presents to the clinic with a 2-week history of visible blood in her urine. Okay, so that's going to be painless, gross hematuria, and that's a hallmark of urothelial or transitional cell carcinoma, right? Maybe that's helpful. She has a 30-year history of cigarette smoking. That's a long time, but she quit 5 years ago, all right? And urine analysis reveals numerous red blood cells, but no signs of infection or proteinuria. An ultrasound of the abdomen and pelvis is performed and shows a mass within the bladder. Which of the following environmental exposures is most significantly associated with this condition? Okay, great. What's the answer to this question here? She's a 55-year-old woman. She has a 30-year history of smoking. She's got visible blood in her urine, but it's also painless. Okay, does that make you think of anything? We're thinking B. Nice. Benzidine, Dr. Sawasan. Nice. Very, very good. All right, and so there's also that mass within the bladder. So there's a bladder neoplasm, and that's urothelial carcinoma. There's no signs of infection or proteinuria. That rules out any glomerular infectious causes. And so, yes, there's blood in the bowel. There's bladder cancer. There's benzidine and beta-naphthylamine that's found in the dyes in the rubber industries. And smoking is the modifiable risk factor here for these aromatic amines. So urothelial carcinoma of the bladder is the most common type of bladder cancer in adults. And it's the strongest environmental risk factor for this malignancy is exposure to these aromatic amines, particularly benzidine. And that's through smoking and industrial exposure here. So asbestos has mesothelioma. Radon would be a basement lung cancer stuff. Lead, basophilic stippling, and PAHs, that would be scrotal or lung cancer, not linked to bladder cancer. So here is the bottom line. Bladder cancer is strongly linked to benzidine exposure, especially in smokers. Okay, now we got a question from the chat. So I want to go over to the community section because we do these as well. Any random questions you guys have? So let me copy your question so that everybody else can see it on YouTube. I'll paste it here and then I will expand it out and drop it there. And then let's talk about it. Okay, so let's do actually a question on that condition, if that sounds good to you. Okay, guys, so this is a question brought to us by Dr. Sawasan. They're asking about TERP now having E. coli infection and resistance after multiple antibiotics from different classes, and the answer they chose was pump efflux. A 68-year-old man develops fever and dysuria 3 days after undergoing a transurethral resection of the prostate. Okay, now he's got fever and dysuria. Urine cultures show E. coli that is resistant to multiple antibiotics, including fluoroquinolones, beta-lactams, and aminoglycosides. Genetic testing reveals the resistance is due to efflux pump mechanism. Which of the following mechanisms is likely responsible for the drug resistance? All right, so basically what's happening is E. coli is going to be very common after catheter-associated UTIs, especially in procedures like TERP, right? You have the transurethral resection of the prostate. And so sometimes these infections are resistant not just to one antibiotic, but also many, right? And that's not because of any enzyme difference or ribosome difference. Instead, it's just the bacterial pumps, right? These efflux pump, they're like the bouncers, and they toss the drugs out. And so and the reason why you know that this is the case is because of the diverse group of organisms here. So it's not just resistance to penicillin, right? It's also fluoroquinolones and aminoglycosides all at once. And so that defense only can come from a broad spectrum mechanic like the overexpression of your efflux pumps. And so here is just efflux pump overexpression. So after TERP, right, there's an increased risk of UTIs. That's why they're saying after TERP. Resistance to multiple antibiotics from different classes, that tells you that it's not some one little thing like a change of beta-lactamase, or it's not like in our other previous question, fluoroquinolones and DNA gyrase, right? This is going to be multi-drug resistance. And so it's going to be the efflux pump, which involves tons of them because it's broad spectrum defense. So E. coli can express transmembrane efflux pumps that remove antibiotics. So that's an example of this question for multi-drug resistance for E. coli, especially after TERP. So TERP causes the E. coli. E. coli has that resistance to broad-spectrum antibiotics. TERP causes E. coli, let's say, and other organisms which are mentioned. So they give you a whole host of them, the gram-negative E. coli infection, but they also have several other genetic adaptations which confer resistance, antibiotic resistance, and that is going to be like a broad-spectrum resistance. And that's in E. coli, you have those greater efflux pumps. All right, so moving on to our next question here. How did you get so jazzed up talking about science? And I'm realizing that we were already at 189, but let's just do another practice question for 189, just a double whammy, right? Because I feel like that was a little bit hard, but here, the practice question. You guys understand this one. Here we have a 55-year-old factory worker, painless gross hematuria. What's the answer? We have transitional cell carcinoma, right? We have painless gross hematuria. There's bladder cancer. So the answer is these aniline dyes. Smoking history and transitional cell carcinoma is caused by aromatic amines. So aniline dyes are one of them. Okay, so that's just another way that this could present on test day. So just be aware of this. The presentation of urothelial carcinoma is gross hematuria and often painless. And these occupational carcinogens, you have to know which ones, the amines, anilines, benzidine, all of those you should be aware of. Aromatic amine exposure, aniline dyes. Okay, so just be aware of those occupational hazards. There's also going to be like a bottom line, transitional cell caused by aniline dyes, especially in industrial workers. So there we go. For this one, we have a 7-day-old male infant with poor feeding, vomiting, and lethargy. The mom reports no complications during pregnancy. On examination, the infant is irritable and has muscle hypertonia. Distinct sweet odor is noted. Restriction of which of the following is going to be effective in treating this patient? Well, what is the answer? I know you guys know this one. The sweet odor. That's classic for maple syrup urine disease. The odor resembles burnt sugar due to the accumulation of branched-chain keto acids. And so the answer is going to be, who knows? Valine. All right. Also be on the lookout for elevated plasma levels of leucine, isoleucine, and valine. Poor feeding, vomiting, lethargy, neurologic findings due to neurotoxicity of accumulated leucine, and also keto acids. Dietary intervention is necessary. You have to restrict the branched chains because you just can't deal with them. You just can't. Autosomal recessive disorder caused by a defect of branched chain alpha keto acid dehydrogenase, leading to buildup of all of these. Tyrosine, that's relevant in albinism and tyrosinemia. Methionine is in homocystinuria, which show marfanoid features. Think PKU. Lysine, not going to be associated with this question. Branched chain amino acids are going to be elevated. Here's the bottom line. Maple syrup urine disease requires dietary restriction of branched chain amino acids, particularly valine, to prevent metabolic crises. All right, so here we go. A 55-year-old woman presents to the clinic with a complaint of persistent cough and occasional difficulty swallowing that has been present for several months. Physical examination reveals a palpable suprasternal notch, and chest X-ray is obtained, revealing a mass in the anterior mediastinum. Subsequent thyroid functions show we have elevated TSH and normal T4. Radioactive iodine uptake. A scan is performed, demonstrating significant iodine uptake in the mediastinal mass. What is the diagnosis? Ooh, okay, I kind of made a mess of that with my highlighting. I'm trying to be a little bit more posse highlighting. That's PAUCI. Basically, mass in the anterior mediastinum. That means that it's localizing the lesion anatomically. We know where it's at. Mass in the mediastinum, and also elevated TSH and normal T4. That tells us that there's a subclinical hypothyroidism. So there's impaired and some impaired thyroid hormone production. And so the answer is going to be C, ectopic. Because there's impaired thyroid hormone production with compensatory TSH elevation. All right, so here's what's happening here. Let's scroll down. Significant iodine uptake. It's a hallmark of functioning thyroid tissue. And so we have thyroid tissue that migrates abnormally during embryogenesis, commonly presented as ectopic. And that's going to be tissue in the base of the lung and mediastinum or anywhere along that thyroglossal duct pathway. So ectopic thyroid tissue results from abnormal embryologic migration of the thyroid gland. Okay, why are they wrong? Mediastinal lymphoma, B symptoms. Lymphomas don't take up iodine, so that's the reason why it's not a lymphoma. Thymoma, myasthenia gravis, that arises from the thymus and does not concentrate iodine. How about parathyroid adenoma? Well, that's hypercalcemia, stones, bones, groans. Right? They don't appear in the anterior mediastinum. How about bronchiogenic cysts? Congenital fluid-filled asymptomatic. They don't take up iodine. So basically, we have to have a differential diagnosis for the anterior mediastinal masses, the 4 T's: thymoma, teratoma, thyroid, and terrible lymphoma. Basic thyroid physiology. So basically, what we need to know here is the pathophysiology as well. There's an embryologic error, and the thyroid fails to migrate, and you have ectopic tissue that remains functional. And so the pituitary compensates. We have the increased TSH due to the suboptimal T4 feedback. And so it's not always sufficient to meet the metabolic demand. And so you have that ectopic gland that can uptake the iodine. Okay, so 90% of the body's iodine actually ends up in the thyroid. So if you see a radioactive iodine uptake, it's like, oh my gosh, that's the thyroid tissue. wherever it is. And so a woman showing up with a mass of her anterior mediastinum, and she's got difficulty swallowing. She's also got some coughing. And so that rules out lymphoma, thymoma, and also cysts and parathyroid tumors. And so the TSH is going up because it might be missing, or she's missing out on something. So TSH is going to compensate. So the bottom line is ectopic thyroid tissue is the most likely diagnosis given the mediastinum mass and elevated TSH levels. Awesome, my friends. Awesome possums. Is it making sense? Are we vibing with that one? We only have 8 questions left until we're finished with all of MBME 30. The original question bank. Yes, W, says I am Rant. All right, here's our next one. Yep. Hematopoiesis already known. Here we have a 50-year-old man presented to the clinic with complaints of muscle weakness that worsens throughout the day, especially after periods of activity. Okay, so muscle weakness that worsens throughout the day. That is huge dead giveaway of hallmark of myasthenia gravis. Yes, there is, I believe. I am Rant. I believe there is. He also reports difficulty swallowing and speaking by evening time. Okay, so all that is leading us to myasthenia gravis. We know that it's myasthenia gravis. And which of the following is the target of antibodies in this patient's condition? Yep, hematopoiesis is right. It is nicotinic receptors. 100% nailed it. Nicotinic receptors. So also improvement, there's the tinselin test with edrophonium that confirms the postsynaptic neuromuscular junction disorder. And also, bilateral ptosis and proximal weakness, that's eye and proximal involvement, are classic for myasthenia gravis. Bilateral ptosis and also the proximal weakness. Normal reflexes rules out peripheral nerve disease. So here's our explanation. They have myasthenia gravis, which is an autoimmune disorder where you're attacking the nicotinic acetylcholine receptors on the postsynaptic membrane, right? So nicotinic receptors. So voltage-gated calcium channels, Lambert-Eaton would be associated there. Muscarinic acetylcholine. So nicotinic is the answer, but muscarinic, these are like autonomic symptoms found in the autonomic ganglia, not neuromuscular junctions, which cause different symptoms like sweating or GI changes. Acetylcholinesterase, that's organophosphate poisoning. And if you inhibit that, it'll cause excess acetylcholine. Muscle-specific kinase, that's like atypical myasthenia gravis variants. And so the most common and classic antibody is going to be nicotinic receptor. All right, so neuromuscular transmission, acetylcholine is released from the presynaptic terminal. It binds to nicotinic acetylcholine receptors in the postsynaptic muscle membrane. Myasthenia gravis autoantibodies block and destroy and downregulate these receptors. You have a loss of receptor availability, progressive weaker contractions, and fatigue. Giving acetylcholine inhibitors increases your acetylcholine levels, improving the transmission. All right, you can barely keep your eyes open at the end of the day, but you're fine in the morning. Myasthenia gravis. Pyridostigmine can provide some relief. Nicotinic acetylcholine receptor antibodies to the nicotinic acetylcholine receptors. Okay, here's the bottom line. Antibodies of myasthenia gravis target nicotinic acetylcholine receptors, causing muscle weakness that worsens with activity. 7 more questions. And by the way, nicotinic receptors, those are the ligand-gated ion channels that respond to acetylcholine. There are 2 types. There's the nicotinic NN. The location is the autonomic ganglia, so the sympathetic and the parasympathetic, and the adrenal medulla. And those activate the postganglionic neurons. And there's also the nicotinic NM, and that's the neuromuscular junction. And that mediates the muscle contraction. And so that's targeted by drugs like succinylcholine, which is a depolarizing blocker, and then other derivatives as well, like non-polarizing blockers. So nicotinic receptors are ligand-gated sodium-potassium channels. They have fast action. And when acetylcholine binds, the receptor changes and you get a conformation, and then sodium rushes in, potassium goes out, you get depolarization. So myasthenia gravis is auto-antibodies against the NM receptors, and botulinum toxin, for instance, is decreased acetylcholine release. And the curated drugs like rocuronium, those are an antagonist that are used in surgery. A nicotinic overdose, that stimulates both of them, and that causes like twitching, hypertension, tachycardia, and that's pretty much all there is to know. NN is the nervous system stuff, and NM is the muscle, the motor endplane stuff. All right, so nicotinic, neuromuscular junction, and also the ganglia, and muscarinic is going to be at the organs. Yep, hematopoiesis is exactly right. So hematopoiesis is talking about succinylcholine and malignant hypothermia, definitely. So basically succinylcholine, that is as we said, the depolarizing neuromuscular blocker. So it binds to those NM receptors, and it causes persistent depolarization, and that causes, malignant hyperthermia, and also like halothine and sevoflurane will do that too. So you have a mutation in your RY1 gene, and that causes defective ryanodine receptor on the sarcoplasmic reticulum, leading to uncontrolled calcium release, and then sustained contractions, and then heat production, all that stuff. All right, do you guys have an answer to this one? What do you think of this one? We have gram-positive diplococci. Which of the following is the most appropriate next step to differentiate the causes of her leukocytosis? All right, 68-year-old woman, hypertension, right-sided chest pain, severe dyspnea while gardening, 20-pack year smoking history, lisinopril, hydrochlorothiazide, pacification of the right lower lung, hemoglobin is just fine, platelets elevated, leukocyte count 24, should be from 4 to 11. All right, so that leukocyte count of 24, that's leukocytosis, and that makes us think it's a leukemoid reaction, right? And so we have to measure the leukocyte alkaline phosphatase score, LAP. She has the elevated white blood cell count, says leukemoid reaction versus chronic myeloid leukemia. The LAP differentiates between the two. LAP is high in leukemoid reactions and low in CML. A bone marrow biopsy is the definitive one, but it's super invasive, so don't do that yet. Flow cytometry, using leukemia and lymphoma to identify clonality, not the first line for distinguishing between reactive neutrophilia. Bacteria culture, you already know the etiology, so that's silly. Why would you do that? Pulmonary function testing for chronic lung disease. Okay, CML has that BCR-ABL, that's the Philadelphia chromosome, chronic myeloid leukemia, and you have a lower LAP score due to the clonal neutrophils lacking the normal enzyme activity. So you have a bacterial infection, cytokine release, neutrophilia, leukemoid reactions, benign, high white blood cell counts with functional neutrophils, LAP score, an enzymatic test reflecting neutrophil activity. So your white cell count could be like boosted way up by an infection and it looks like leukemia, and it's a leukemoid reaction. Wild. So a leukemoid reaction is that benign reactive neutrophilia, so an infection or stress, and has a really high LAP score. But your chronic myeloid leukemia is malignant myeloproliferation, and that has a low LAP score. So LAP in a leukemoid reaction, the neutrophils are really mature and they're functional, right? So they have increased LAP, but in CML, Philadelphia chromosome, 922, basically you're producing in excess, but you have dysfunctional or immature neutrophils. And so they have low LAP because they don't produce that LAP because they're malignant clones. So the CML is cancer, you have low LAP, and leukemoid is going to be high LAP. All right, so here is the leukocyte LAP score, helps differentiate leukocytosis causes, particularly in suspected infections. 6 more. Okay, so here we have a 42-year-old woman presented to the clinic with a 2-month history of frequent diarrhea and weight loss. She's also had intermittent severe burning that improves slightly with food. And we have multiple small ulcers in the jejunum. What's the most likely cause? And look at that, calcium is elevated. So it improves with food. And so that's going to be some sort of a duodenal ulcer, right? Yep, Zollinger-Ellison syndrome for the multiple ulcers. You got it. That's 100% right. Yep, Zollinger-Ellison syndrome. You have that calcium, so hyperparathyroidism and pancreatic process, multiple small ulcers is going to be Zollinger-Ellison syndrome, the proximal jejunum, because it's not where they should be. Frequent diarrhea and weight loss, gastrin-induced hypersecretion, and activates the pancreatic enzymes, causing malabsorption. And so C, you got it right, 100%. So defective antral pylorus relaxation, gastric emptying problem, that's seen in gastric outlet obstruction. H. pylori infection would have ulcers in the duodenum and the stomach, does not explain the jejunum or elevated calcium. Autoimmune destruction of the parietal cells, that's chronic atrophic gastritis, B12 deficiency, causes hypochlorhydria, not hypersecretion of ulcers. Opposite physiology, intestinal villus blunting would be celiac disease, can cause diarrhea, weight loss, but not peptic ulcers. All right, so we have to review the gastrin physiology. Gastrin is secreted by the G cells in the antrum of the stomach to stimulate the production of the parietals, stimulate acid production by parietal cells. ZES, a gastrinoma, usually in the pancreas or the duodenum, causes unregulated gastrin secretion, resulting in acid overproduction. Associations, MEN1, parathyroid tumors, hypercalcemia, pancreatic tumors, gastrinomas, pituitary tumors, prolactin. Cool, I like that. You guys are finishing each other's words now. I don't know what that means for you guys, but great, I'm happy to see it. Ulcers beyond the duodenum. Severe recurrent ulcers despite therapy, diarrhea, weight loss, high calcium, all of these things, associations with the MEN1, these are all associated with gastrinomas. All right. So ulcers, they can burn right through your jejunum. And typically an ulcer pain gets better with food, but when they're beyond the duodenum, especially the jejunum, you should think of Zollinger-Ellison syndrome leading to jejunal ulcers and diarrhea. Yeah, you guys are in symbiosis there. Nice. Let you guys stew on this one for a second while I do a little bit of coding. All right, here we go. A 64-year-old woman with type 2 diabetes presents to the emergency department with a 5-day history of increasing shortness of breath and also yellow sputum and fatigue. She lives alone. Was recently hospitalized for diabetic foot ulcer treatment. On examination, her temperature is 101.3 and blood pressure is 105/70. Lung auscultation reveals decreased breath sounds and agophony over the right lobe. Lab studies show a white blood cell count of 3,200, which is low. And chest CT shows nodular regions with ground glass opacities. Serum tests for galactomannan are positive. A positive serum test indicates the presence of which of the following components. Okay. So really the only thing here is we have these galactomannan tests are positive. And galactomannan is a polysaccharide component of the cell wall of the Aspergillus species. So does that help you answer the question? Breath sounds, agophony, yellow sputum, diabetic foot ulcer treatment, that's important, right? Yes, fungal cell wall, 100%, Aspergillus, yep. So the CT reveals nodular lesions. These are also the halo sign, right? Invasive Aspergillus, ground glass opacities, nodular lesion, halo sign, aspergillosis. White blood count is at 3,200 with neutropenia, profound risk of no significant risk factor for fungal infections. Recent hospitalization and diabetes, immunosuppression due to chronic disease, right? Increase the fungal risk. Halo of death, right? Invasive aspergillosis. So galactomannan is a polysaccharide found in the cell wall of Aspergillus. Bacterial endotoxin, lipopolysaccharide, is found in gram-negative bacteria, not fungi. So nope. Viral capsid protein, serologies of PCR for viral infections, wrong because viruses do not allow the halo signs. Bacterial exotoxin, toxin-mediated illness like tetanus and diphtheria, is wrong because no exotoxins are involved in fungal pathogenesis. Mycobacterial lipid cord factor. Fungal sketchy time. But Aspergillus can kill immunocompromised patients in days. And it starts with something as subtle as just a little cough, and then there's a lethal lung lesion. And yep, so diabetic patients, neutropenia, presenting with that cough. Watch out. Watch out, my friends. Watch out. Here's the bottom line. Whoa! Hello. Positive serum galactomannan indicates fungal cell wall components, suggesting possible invasive aspergillosis in immunocompromised patients. Woohoo! Oh yeah. Oh yeah, the Duff Man. All right, here's a nice factoidy little question for all you factoid lovers. If I were to say cyclosporine, what would you be thinking of? What would you be thinking of? 58-year-old woman, history of rheumatoid arthritis, has started on immunosuppressive regimen. Targets a protein crucial for T cell receptor signaling and interleukin-2 expression. New onset hypertension, her gums have become swollen. Which of the following is most likely inhibited by the medication? Nice. Okay, thinking of some good things. Yes, calcineurin. Nice, nice. Indeed it is. So they're targeting a protein that's crucial for T cell receptor signaling and interleukin-2 expression. This is the giveaway, right? That directly implies calcineurin, and then that's essential for your T cell activation pathway and IL-2 production. Also, new onset hypertension. Is that what she's got? New onset hypertension. That is an adverse effect of cyclosporine, which is a calcineurin inhibitor. Swollen gums is also associated with this as well. Rheumatoid arthritis, immunosuppressants like methotrexate, and calcineurin inhibitors like cyclosporine block the IL-2 transcription by inhibiting the dephosphorylation of fat. Calcineurin is a phosphatase that activates transcription factor, NFAT, which is required for IL-2, calcineurin, and there's calcineurin inhibitors like cyclosporine and tacrolimus. They're both calcineurin inhibitors. They're used in autoimmune diseases and transplant rejection. They cause hypertension and gingival hyperplasia. Track 2 is for erythropoietin, mTOR, cell growth, sirolimus. Sirolimus is different, mTOR inhibitors. They affect the IL-2 response, but not associated with gingival hyperplasia, like tacrolimus and cyclosporine are. So T cell activation, calcineurin, dephosphorylating NFAT, which then moves the nucleus to trigger IL-2 transcription, which is super important for T cell proliferation. All right. So yeah, you guys are talking about tacrolimus. That's a calcineurin inhibitor as well, and it's used to prevent organ transplant rejection. It suppresses T cell activation by inhibiting the IL-2 transcription. And there's a question by hematopoiesis. What's the physiology with gingival hyperplasia? Immunosuppressants are a big one because it stimulates the fibroblast proliferation, so that increases the TGF-beta. And also anticonvulsants can cause this. That promotes fibroblast growth. So usually it's the fibroblast stuff, right? And then the calcium channel blockers as well, that increases the expression of the growth factors in the gingival tissues. So tacrolimus is going to be associated with gingival hyperplasia a little bit less than cyclosporine is, even though they're both calcineurin inhibitors. It's involving the fibroblasts and the matrix components, and they're stimulating the production of inflammatory cytokines and growth factors. Yeah, so basically the gingival hyperplasia is fibroblast stimulation, extracellular membrane accumulation, and the impaired degradation. So here is the bottom line. Calcineurin inhibitors can cause hypertension and gingival hyperplasia in patients on immunosuppressive therapy. Cool. Very nice. Very nice. Ooh. So we have a 65-year-old woman with a history of sleep apnea and obesity presents to the clinic with increasing lethargy and shortness of breath over the past few months. She reports that she uses her CPAP machine irregularly, and she denies smoking and drinking. Her blood pressure is 138 over 86. Respiratory rate is 22, BMI is 35, oxygen status is 89% on room air, and hemoglobin is 19, so that's elevated. Which alteration is most likely responsible for the elevated hemoglobin? Hematopoiesis probably likes this question. Yep, we have the increased erythropoietin production. So she has chronic hypoxemia in that, and then she uses the CPAP irregularly. And so it's untreated obstructive sleep apnea means that there's recurrent nocturnal hypoxemia. And so you have an oxygen saturation of 89% on room air. That's hypoxemia as well. So intermittent hypoxemia, the kidneys are responding by increasing the EPO. Polycythemia, elevated red blood cell mass. There we go. Obstructive sleep apnea. There's the pathophysiology. All right, guys, 3 more questions. Then we're donezo with MBME 30. Cause so the hypoxemia, which causes the kidneys to be like, oh my gosh, I got to start to make more of that. They make more hematocrit. All right, so we have a 3-year-old female is brought to the pediatrician by her parents who are concerned with a light brown patch on her left shoulder. They report that the patch has been present since birth, but has not changed in size and color over the past year. The child is otherwise healthy with normal growth and development. On examination, there's a 4 centimeter, uniformly tan, flat, oval macula on the left shoulder. The rest of the physical examination is remarkable, including skin, neurological, or ocular assessments. There is no family history of neurological conditions. Which of the following is most likely diagnosis? All right, a medical word for birthmark. So this is actually light brown patch, right? And that is the color of cafe au lait. In its present sense, birth, so it's congenital, right? And so it's cafe au lait spot. And it's uniformly tan, flat, and oval macule. That distinguishes it from any sort of irregular nevus. And so it's not Becker's, because that's hyperpigmented with overlying hair. The nevus depigmentosum is hypopigmented. It's lighter than the skin. Juvenile xanthogranuloma is yellowish. Congenital dermal melanocytosis is a bluish-gray lesion on the scrotum. And so there are some associations like NF1, but the pathophysiology here is you have excess melanin in the basal keratinocytes. You have a congenital origin, present since birth, and it's stable. And if there are multiple due to mutations in neural crest, then it's going to be neurofibromatosis 1, though. So there are 3 images, reference images, and there are 4 concepts. So I need to make them both have 4. Okay, does that one make sense? But yeah, so a kid's got 1 to 2 cafe au lait spots and no family history, no neurofibromas, and no leash, then yeah, you're right. It's likely just birthmarks. But if it's greater than 6, then it's going to be a neurofibromatosis 1, and you have to do some genetic counseling for sure. McKean Albright, it has the irregular stuff. That's the coast of Maine. And there's also like tuberous sclerosis, and that more commonly has the ash leaf spots. Okay, how's the day going? Moise, life is good. I've just been chilling, just doing some coding, and we're almost finished with this, so I'm really excited about that. Wait, all right, folks, let's get back to business to defeat the Hun. All right, guys, we only have 2 more questions. Can we do it? Do we have it in us? Will we quit? Will we give up the fight? Is it time to surrender? Or can we do 2 more questions? I don't know, guys. I don't know. Let's do 2 more. Let's do it. A 67-year-old man with a history of chronic obstructive pulmonary disease presents to the clinic with worsening dyspnea and productive cough for the past 5 days. He also reports low-grade fever and malaise and a long-term smoker with a 40-pack-year history. Which of the following is most likely the mechanism for the patient's hypoxemia? Diminished breath sounds. Blood pressure 128/76. Dense consolidation of the right upper lobe. Impaired gas exchange. Is that what you guys are thinking? All right. So we have a productive cough. There's low-grade fever and consolidation. That's classic lobar pneumonia. Lobar pneumonia should make you think of what? Oh, we're thinking D? Is that what we're thinking? Anybody have any other ideas? Sidal says VQ mismatch. You guys should fight. Just kidding. What is the right answer? Is it diffusion-limited gas exchange? Or is it ventilation-perfusion mismatch? Okay, so let's look over like the most important aspects of this question right here. So I kind of highlighted way too much, so I'm going to unhighlight this stuff. Okay, so here it is. Dense consolidation of the right upper lobe. That suggests lobar pneumonia. That blocks the alveolar ventilation in that area. Also look at this. pH 7.44, PaCO2 is 31, and our bicarbonate is at 20. That tells us there's respiratory alkalosis with compensatory low bicarbonate. And so this patient is hyperventilating, all right? Hyperventilation. There's respiratory alkalosis, compensatory low bicarbonate. The bicarb is low, all right. And PaO2, 64. This tells us that there's hypoxemia despite the compensatory hyperventilation. And so what we're thinking is C, ventilation perfusion mismatch. Ventilation perfusion mismatch. And so there's alveolar consolidation, and that blocks the ventilation to the regions of the lungs, right? So the blood still perfuses that area. You still got blood, but you don't have the air there. There's no ventilation. And there's an intrapulmonary shunting. That's the key mechanism for the pneumonia-related hypoxemia, intrapulmonary shunting. And so they have pneumonia that's superimposed on their COPD. So they have COPD and also pneumonia. And so you have a ventilation perfusion mismatch because the consolidated alveoli received no ventilation, like hardly any. Maybe a little bit, but just barely any. And yet they still get perfused. They still get the blood. So you have areas of low V resulting in hypoxemia. And that's the most common cause of hypoxemia in pneumonia. And it does not correct completely with supplemental oxygen, right? But what about these other answer choices? Widespread alveolar collapse. Well, that would cause severe hypoxemia, right? That's more like atelectasis. How about B, which is what a lot of us were saying? Inadequate ventilation due to the airway obstruction. Well, that's COPD exacerbation of asthma. And this person's main issue is alveolar filling, not bronchial obstruction. Alveolar filling is the problem. Ventilation perfusion is correct answer. Diffusion limited, gas exchange across the alveolar membrane. That would be seen in fibrosis and high output states. That's not localized consolidation. Fibrosis and high outputs is diffusion limited. And then high altitude exposure causing low inspired oxygen levels. There's no evidence of altitude exposure here. Okay, so why the lung is leaking oxygen? Pneumonia-induced VQ mismatch, leading cause of hypoxemia and pulmonary infections. Widespread alveolar collapse is atelectasis, COPD exacerbation. D is pulmonary fibrosis and emphysema and exercise-induced hypoxia. Diffusion limitation is rarely the cause of hypoxemia at rest and does not explain the focal findings of fever. VQ mismatch is associated there with mechanism of pneumonia and COPD exacerbation. And then you have an infection, so there's higher risk of pneumonia, and smoking destroys the alveolar macrophages and predisposes you to the infection. So let's explain this like super duper simply. Very, very, very simply. Basically, VQ mismatch is a spectrum. You have low ventilation to zero ventilation. And when the alveoli are completely filled with fluid, like in lobar pneumonia, ventilation goes to zero. Perfusion still continues. That is a true intrapulmonary shunt. The hypoxemia in pneumonia typically does not correct fully with 100% oxygen, and that supports the shunt physiology. And so, yes, the best answer is definitely VQ mismatch, but I can see as well, like the most precise term for lobar consolidation and complete ventilation loss is an intrapulmonary shunt. And so, yes, that is definitely like a very, very good way of saying it. But in pneumonia, yes, there's actually no ventilation, so there's a shunt, definitely more accurate, and you get a gold star. You get a gold star, my friend. Okay, here's the bottom line. Ventilation perfusion mismatch in the affected area is most likely a mechanism for hypoxemia in pneumonia. All right, guys, last question. The last question. Hallelujah. Last question. Let's go. Here we go, guys. Question 200. We've been at this for days, over 4 days, and we finally are finishing today. Okay. All right. Last question. Who's going to get this right? The first person to get this right. If there's a way that I can, no, not 20 push-ups. No. Oh, I wanted to do the question first. Oh, I was so excited. All right. I'm going to do push-ups while you guys solve the question. Okay. There we go. I should stop promoting the Twitch channel. Oh, okay. Here we go. A 31-year-old man presents to the clinic with a 6-month history of unexplained weight loss, increased sweating, persistent anxiety, unusually hot, even in mild to warm environments. His heart rate is 110 beats per minute, non-tender, diffusely enlarged thyroid gland. Lab studies reveal an undetectable thyroid-stimulating hormone, an elevated T4 and T3, most likely due to hormones exerting their action through which the following mechanisms. This is a good one. All right, you guys can phone a friend. Hematopoiesis is pretty sure that thyroid is a cell surface receptor, probably G protein. What are you guys thinking? This is for all the marbles. Dr. Sawasan says B, not sure. This is a really good last question. I'm glad there's some good conversation about this. All right, so weight loss, heat intolerance, anxiety, sweating. Can we all agree this is hyperthyroidism, undetectable TSH, and elevated T3-4, so it's primary? Anybody feel super confident? All right, so there's unexplained weight loss, heat intolerance, and so this is an anxiety and tachycardia. Thyrotoxicosis, right? Thyrotoxicosis. And there's diffuse non-tender goiter, and that's most consistent with Graves' disease, right? Graves. Okay, so that's an autoimmune hyperthyroidism. There's elevated T3 and T4, and there's suppressed TSH, and that confirms primary hyperparathyroidism. So we got all that down. Cool. Now, thyroid hormones, they're lipid soluble. Does that help? Thyroid hormones are lipid soluble. They can act intracellularly, and they bind nuclear receptors to regulate the gene transcription. So they behave like steroids. Yes, 100%. You got it right. Hematopoiesis C. They behave like steroids. They cross the cell membrane, they bind to the nuclear receptors, and they alter gene transcription, changing the protein synthesis. They are essentially going to exert their effects by entering into the cell and binding nuclear receptors. And these receptors directly modulate the DNA transcription, and they alter the gene expression. And so, yes, 100%. Well, you got it right in the end, and that's all that matters. That's all that matters for me. And now let's talk about each of these. A, that's used by insulin and IGF. Not thyroid hormone. Insulin and IGF use this pathway, the PI3K pathway. PI3K pathway, insulin, IGF. Intrinsic tyrosine kinase. Well, this one is going to be insulin and also your growth factors like EGF, PDGF. D, ligand-gated ion. That applies to neurotransmitters like GABA and acetylcholine. Activation of adenylyl cyclase through the G proteins. That would be like TSH, ACTH, PTH, and glucagon, not T3, T4. So the hormones use different receptor systems, and peptide hormones are on the membrane receptors. Steroid and thyroid hormones are lipid soluble that cross the membrane, and they bind to intracellular receptors, and heat intolerance, weight loss, anxiety, and hyperthyroidism. So there you go. Good job, guys. Here's the bottom line, and thank you so much for the gifted sub. I really appreciated that, Moise. I'm going to use that to buy a cleaner for my huge water bottle. We did it, guys. We finished WME 30. It only took us 4 days. But the bottom line is hyperthyroidism symptoms arise from thyroid hormones binding to and modulating gene expression. All right. Moise, really appreciate it. And let's see here. I just finished this overlay, so I'm curious what you guys think on this one. So if you guys are watching on YouTube, this has been fun. You can always join us on Twitch to kind of participate in this. I think I'm going to add some new features like labs are going to show, and also I'm going to have polling systems so that everybody on Twitch can vote, and you'll be able to see each other's votes. rolling in. I think I'll do that. But yeah, we're going to have lab values. We're going to have polling systems. We'd love to see if you guys have any other feedback on what you'd like for me to add. But if you're watching on YouTube, thanks so much for joining. If this has been helpful, then like and subscribe, and we'll see you guys in the next video. Thanks, Moise. Take care. All right, I'm going to stop the YouTube stream, and then we can start talking about some philosophy